Hi, Mohan. Can you hear us?
Yes.
Mhm.
Okay. I'm just catching up. So I'm in my department all geared up for next 4 hours,
That's
four
fine.
and a half hours.
Yeah.
Okay. People are getting in. कि कौन है मेरी candidate ही है क्या CMC REPM they're logging in. Okay. Sharmishta, you're there? Yeah. I don't know what are they doing. Okay. Tell
Vani
me.
has joined in. Yeah. No, the thing is that for the workshops online, people have been playing recorded welcome messages by Dr. Sudha and Dr. Nina. So it's like a 2-minute and a 3-minute welcome message. Would you like us to do that, or we just start right away whenever the time starts?
I think we'll do that a couple of minutes before, it's 1:30, so 1:25 will start off.
Okay, so then you will be introducing the workshop.
Yeah, after that is after their introduction, whatever that video is.
Right.
Okay, that, yeah, I'm going to keep it very low frills affair. So introduction will be a brief 2-line or 3-line of what we hope to achieve out of this. So it's going to be probably half a minute or 1 minute.
So
Yeah.
why we need to discuss this is because these guys will then play the videos accordingly. And so you will come on screen soon after the videos.
Yeah.
And that will, okay, so you introduce the workshop, and then thereafter I take over as the MOC. And I just introduce the chairpersons, that's it, the experts, which includes you as well.
Yeah, so okay, I need to have the program with. So the first session is mainly on the students and the experts, no?
Or you could just say, I'll invite my co-experts for this session, and you could just take it on from there. The CV.
Yeah. Yeah, so CV, I'm just downloaded that, but it's in order.
Yeah. Varun, aap hai wahan?
Which I can probably go up, down, no?
Yeah, we just kind of ran that video, not the video, the CV presentation. And Varun, agar aap hai, to ek baar wo on kar sakte hain, ek baar हमारा CV PPT flash kar dijiye zara. So
we just tell them speaker. Okay, so chairperson ko just we kind of tell who they are, no? That's all. Experts or chairperson.
Yeah, yeah. So Teresa, you said would be unable to join. We did this change just now.
Yeah.
And then following this, agla dikha dijiye. This is what is happening. 3 presentations. And then it's session 2. These are the chairpersons along with their designations.
Yeah, so we just introduce them, with the whatever is that. Yeah, I think that's quicker.
Yeah, designation. So you are on till this point, right? You are conducting it from there till this point. Is that okay? Huh?
Because you are speaking in this session. Yeah.
I'm speaking in this session, yes.
Yeah, okay. So, okay, that sounds fine.
Right. And then I'll take over the session 3, just to introduce the chairpersons.
So who is going to flash this one? Should I share the screen for this?
No,
or
no.
they will do?
I will be doing it.
Yeah.
Okay. So you have to be there all along 4 hours. Huh?
Yes, sir. Yes, I
Okay.
will be there.
Because, okay, that will make it easier.
Yeah,
So only
also
this.
we will also try to put a timer for all these speakers.
Yeah.
So that everybody will complete on time.
So only the once the speaker come in, they have to share that screen. That switching over has to be smooth. Yeah.
Yeah.
Okay, that sounds fine. Prerna Gupta. And even I think speakers also will briefly introduce only. We are not going to make it very elaborate. First two lines or something, where they are from. That's all.
Yeah.
So probably it need not be flashed because the speaker ka the first slide hopefully is that. Is that okay? You know?
Yeah. This is just a backup that these
Yeah.
guys.
Yeah. That sounds okay.
Okay, so we are good here. This is done. And there are those 2-minute videos which we play between 120 and 125, right?
I will
125 ko bhi kar de, theek hai, it's okay.
Yeah, this is the video. You can.
This is one video.
Dear friends and colleagues, I feel extremely privileged and honored to welcome you all to this academic session of 17th Annual Conference of Indian Fertility Society. Before we get started, I would like to express my sincere appreciation to all of you who generously helped us make this event to become a success. Your passion and ideas have helped us to achieve our goal. Today, I can say that the prestigious Indian Fertility Society has accomplished a recognizable position among fertility societies. It is a pleasure for me to welcome all the delegates of the workshop from all over India on behalf of Indian Fertility Society. Your presence is highly appreciable by all of us. Further, a warm welcome to all industry representatives who are present here to highlight us. I wish you all a great success. Thank you very much. Namaskar.
Okay.
So, a very good morning and
Arvind and Siddharth are here.
Yeah.
good morning and welcome to all the delegates and faculty for these workshops. The pre-Congress workshops for the Fertivision 2021 have been designed and programmed very thoughtfully by the conveners and co-conveners so that the delegates can go back home enriched with knowledge and with takeaways from these pre-Congress workshops. I welcome all the delegates, all the faculty who are involved in these workshops, and once again wish all the success for these workshops. Thank you very much.
Okay.
And followed by these two videos, we would be putting the this presentation CVs of experts, which I've already showed you before.
Yeah, so you will put that, and by that time I will take over, and yeah, that should be okay then. Yeah. So probably I just need to have the program in front of me. Program na gadbad hoga.
It's the first thing posted on that group, or I can send it to you again.
Yeah, no, I have that. I'm just. Oh.
Yeah, Varun just posted it again.
Yeah, so Teresa is actually sitting on, going to come back. She will be on train, so I think that should be okay. What about the students? Bhavani Shekhar, Dr. She's from.
Bhavani has joined, and I believe Sharmishta has joined. Bhavani is from Gangaram. She's a second year fellow from Gangaram, National Board of Education fellow.
Okay, and Ritam Kumari is from
UCMS.
Okay.
UCMS.
Okay. So they will introduce themselves probably once it starts, like when they are, I think their first PowerPoint. Okay. Where is my candidate? Madam is here. Yeah.
Dr. Anupama has joined as well. Hello, Dr. Anupama. Okay.
Dr. Siddharth, Dr. Arvind, welcome. Hi.
Good morning, sir.
Morning. Arvind also is logged in. I think I can see that.
Yes. Hi, Arvind. Hello, Siddharth.
Hello, ma'am. Good morning, ma'am.
Good morning.
Okay.
Good afternoon, sir. Good afternoon, ma'am.
Hi.
Hi, sir.
Okay. I'm not sure how many are registered. Any idea, Ruma, about beyond 10 and complimentary?
No, not really. I'm expecting some 40 delegates to join. So
Okay, then there'll be a virtual party after this if there's 40.
we'll do a virtual party. Yeah.
आजकल लोग बैठते हैं ना, they take
I
a.
have my tea ready, so in case anyone wants this.
आप लोग घर में हो, मैं यहाँ पे ऑफिस में आके बैठा हूँ, पानी लेके बैठा हूँ.
Pani pee.
That's all we can do.
Right.
I thought I didn't want to take chances at home. Let me just sit here, and I thought I'll get distracted there.
Priya is conducting, I think, a workshop in Bhopal as we speak now. It was a 2-day workshop, and she confirmed she'd come.
Okay, what is the topic?
Her topic is, I think, writing a research question, important one, and writing a protocol for systematic review.
Okay. So protocol is something I've spoken. So in case there is a backup pen, I can always take over just in case. I have presentations of those.
Yeah.
Not be a problem.
I saw Raju's presentation. I think that includes some slides on research question as well. So maybe that bit can be covered.
Just in case, because Raju also sent me the slides. Yeah. I'm just seeing if I have those. Okay, protocol development. Yeah, I have that. That should be okay. See, what happens is actually it's here we are taking right now a 2 weeks workshop where 1.5 hours or approximately 1.5 hours, so 6 days a week, 12 days. And we kind of run through each of these topics over 1 or 2 days, like session. So like risk of bias, and then next day there'll be a hands-on session. Similarly, protocol, and then a hands-on on protocol. So that's the, I'm not still satisfied in the sense it still requires more discussion, but virtual, people are not able to really, I think, stay beyond 1.5 to 2 hours, So, so when it used to be conducted in a physical form, it used to be a 1-week session where from morning 8:39, we had in our place, there'll be some 20 computers and everybody is on the computer, and some lectures and discussion, everything goes on. So it's like a 6 to 8 hours extent. So 6 days. So it is to be like from starting till finish. But virtual, we have just kind of restricted it.
Yeah.
Problem is, as I read, things have moved on even beyond this. This is now considered very, very basic.
Yeah, we realize that, but we also realize that there's a complete lack of information on systematic reviews, what they are, how to read them. And I would still think this would be very useful.
So I just gathered yesterday, actually this week's session for my course is systematic reviews. So a couple of things that I got enlightened was, see what they're doing is that they're doing a primary RCT. Let's say 2 or 3 centers are doing like COVID, and prospectively they will do a systematic review. So before that result comes into the published journal in a published manner, they will also incorporate the data in the systematic review.
Yeah.
And at least yesterday they showed a couple of examples where the primary study and the systematic review of a couple of more studies has come in the same issue of Lancet and other things, especially for COVID and other things. So what essentially is being done is, one of the things that we keep harping on systematic review, it's a retrospective one. Whereas here what they do is they kind of streamline the protocols. And then even if, let's say, you and me are doing a trial, and if we are on the same page in terms of protocol, you can cobble up a systematic review. without knowing the results. You just feed in the data at the last moment.
While the trials are underway.
Yeah, yeah,
Wow.
yeah.
Okay.
So that's the new thing that's happening abroad. So
right.
that's one thing. I was just thinking about it. It's a good move.
Yeah. Yeah.
That's one. But it also is like you can always do a multi-centric trial on the same protocol.
Mhm.
But I reckon that what problem can happen is, let's say I'm launching a trial and I'm already way ahead in terms of starting it, and I can share that idea with any other unit, and then if they agree on the same protocol, they can launch it simultaneously, even if there's a time lag.
Mm.
And then we all kind of synchronize and get it together for the systematic review. So these are kind of prospective systematic reviews in some sense.
Right.
Yeah, and I've also understood IPD meta-analysis is going to be the way forward.
Yeah, I look forward to hearing that. Surely.
Actually, it is pretty complicated. The recent, whatever the interaction we had, it's not easy in the sense it is more for subgroups.
Right.
It will give you more information if the effect is, the treatment has an effect, how it is playing out within subgroups. So the word they call it is precision medicine. You kind of move towards that. All that has been happening. Okay, if you want to finish and take a break and come back, or
it's 1:20, so I don't think we would be able to take a break. Varun, delegates कहाँ login करेंगे? हमें इसके through पता लगेगा या आपके पास कोई और portal है?
Just check, where is this called?
वरुण आप नहीं है? Dr. Anupama, hello.
Okay.
Hi, Dr. Uma.
Hi.
Yesterday I was the only one who was offline.
Yeah.
Online, sorry.
Most of us were very much there without our masks, and of course, so people don't care anymore. I guess we have too much of this. Yeah, but I still have my mask on in some of the pictures. Yeah, somewhere it strikes, oh, this is not the way to go ahead.
I had a nice evening with Shatrughan Sinha. I was listening to his.
Okay, I missed it completely.
Oh, you missed it? Okay. Okay.
Subha se wahi baithe the. So.
Yeah. Hello, Dr. Anupama. I don't know, we have not met in person.
But I have heard about you. I think you went to Aberdeen after I did.
Okay, yeah. Okay.
So I heard from Batty that you were coming next. Okay. And then, of course, from Dr. Nina.
Okay. So all positive things, I hope. Yeah.
Yeah, all positive.
Okay. Yeah. Biased views honge wo sab. Systematic review mein yahi sab ghumta rehta hai, bias ki tarah.
And the other reason was that I have always wanted to come to you for your workshop to CMC Vellore, but I have not got a chance. So I was just thinking if once this COVID is over, if I could come.
Yeah, actually right now we have a Cochrane workshop going on, but just to share with you that I think in October, the Cochrane network kind of got inaugurated in India. So there are 11 of them, and one of them is in PGI. Then one in, I think AIIMS has.
AIIMS Delhi.
AIIMS Delhi. And all of them will be conducting their workshops, though we have been doing it for a fairly long time. I was just sharing that right now a virtual one is going on, which is spanning 2 weeks, where we take 1.5 hour session in the evenings.
That's done, or is it like ongoing?
It's almost done, ma'am. But I can keep you in loop.
I do want to be in the loop for it.
Yeah, sure.
Thank you.
We are going to have a very no frills workshop now. We'll be very quick in moving through, because I think we will try to have some interaction. Otherwise, afternoon workshop on a research topic is not a very easy one to pull off. I just
So you have the inauguration as well, or we just begin?
We have a couple of videos, I believe, which is pre-recorded. So we will start that at 1:25 from Dr. Sudha Prasad ma'am and Dr. Neena.
No.
Yeah.
Okay.
The idea is to basically we'll be focusing on RCT systematic reviews. And if students understand that it all starts from the building blocks, that's an RCT, and how you critique an RCT, it kind of then leads you towards what actually is being done in systematic review, which is almost the same thing. So we thought we will involve students on that and then play on from there. Yeah. Varun, we are a couple of minutes away. ये virtual में यही problem है कुछ.
I've just asked him to check on the delegates. He doesn't have that portal. Somebody else is looking after. But I believe the people will join in by 1:25 or so, not before. So
Okay.
1:25, we could start at 1:25, one way or the other, right? So at
Yeah.
least, right.
That's okay.
Yeah. This is being recorded as it is. So if we have to share some of this, we're happy to do that, no?
Yeah.
Yeah. So Varun,
Yes, ma'am.
you are there. Great. So 1:25 पे आप वो videos play कर दीजिएगा और उसके बाद फिर
Also, I'll put you live on the front end so that the delegates can see we have started the session. So
oh,
whatever discussion we are doing, whatever video we will be playing, that
Yeah.
will be going directly to the virtual platform. Front
Okay.
end from the delegates can see by putting their email address.
okay, right. Sure.
I think the experts, one by one, they can invite one student each, so they can mark out that in the same order, I think so. Dr. Siddharth can introduce the first, then just call upon the first student and next in that order. I will probably, I think Dr. Anupama can invite the second student and then I can do the third, because otherwise we'll be a little biased.
Yeah.
So this is not the student link. Sharmishta is not there.
Sir, Mr. is there, ma'am. वो
Bhavani.
मेरे department login पे है. She is at there, CMC. What Ritam Ranjan? I think that's the third student.
Ritam
Yeah.
Kumari.
Yeah, I have. It's showing now. We have admitted her. Yeah.
Bhavani is there.
Yeah, we are okay.
I think it's 1:26. We can start, and I'll be putting you live so people, delegates can see you on the front end virtual platform.
Yeah.
So yeah. So I'll give you a countdown.
Yeah.
And then you can start.
So the video you will start, no? That's all.
Yeah. First, I'll start with the video.
Yeah. After that, I'll take over.
Yeah.
Dear friends and colleagues, I feel extremely privileged and honored to welcome you all to this academic session of 17th Annual Conference of Indian Fertility Society. Before we get started, I would like to express my sincere appreciation to all of you who generously helped us make this event to become a success. Your passion and ideas have helped us to achieve our goal. Today, I can say that the prestigious Indian Fertility Society has accomplished a recognizable position among fertility societies. It is a pleasure for me to welcome all the delegates of the workshop from all over India on behalf of Indian Fertility Society. Your presence is highly appreciable by all of us. Further, a warm welcome to all industry representatives who are present here to highlight us. I wish you all a great success. Thank you very much. Namaskar.
And welcome to all the delegates and faculty for these workshops. The pre-Congress workshops for the Fertivision 2021 have been designed and programmed very thoughtfully by the conveners and co-conveners so that the delegates can go back home enriched with knowledge and with takeaways from these pre-Congress workshops. I welcome all the delegates, all the faculty who are involved in these workshops, and once again wish all the success for these workshops. Thank you very much.
So I can take over. Yeah. Okay. Very good afternoon to all dear friends, colleagues, and all participants who have joined for this workshop. I'm Dr. Mohan Kamath. I'm from Department of Reproductive Medicine and Surgery, CMC Vellore, the convener for this SIG group on research methodology for IFS. Myself and my co-convener, Dr. Ruma Satvik, who is from IVF consultant from Gangaram Hospitals, New Delhi. We welcome you all for this 4 hours workshop on systematic reviews. I'll keep it very brief. We hope that we are going to be able to give you a flavor of systematic reviews. This is not a very exhaustive workshop. It's more about giving you some idea about how a systematic review is done. And probably once you are able to get some information on that, you can build on that information and probably start looking at performing one yourself with a team. And at that stage, it will require a more exhaustive workshop and probably that would help, and we can look at that at some time in the future. Now, we have built 3 sessions in this workshop. And the first session is to basically give you an idea about how to critique a primary study. We have picked up RCT model for this workshop because most of the systematic reviews what we are used to in clinical practice are based on RCTs. So it's important that we have that skill to critique an RCT, and that is what is the basic requirement for conducting a systematic review. So we have 3 students who are in various stages of their courses who will be critiquing 3 articles, and we have a expert group whom we will probably invite for their comments. So without wasting any more time, we will just switch on because we want this to be an interactive session. And we hope that we have a good number of questions which we can probably address during the sessions. Okay, so can I request the slide for the experts? Yes, the next one, please. So 3 experts I'm replacing currently just because one of our colleagues could not make it. So I'm there. Dr. Siddharth Nagireddy is Associate Prof, and he's from Sri Ramachandra Institute of Higher Education Research, Chennai. He's one of the first MCH from this country. He'll be joining us along with Dr. Anupama Bahadur. She's Senior Professor, Unit Head, OBGYN, AIMS Rishikesh. So I welcome both the experts, and I can request Dr. Siddharth Nagireddy to invite the first student.
Yeah, I'm happy to invite Dr. Bhavani Shekhar. She's currently doing her post-graduation SG RH New Delhi. So she's going to present on hysteroscopy before in vitro fertilization, that's INSIGHT trial, a multi-center randomized controlled trial, for which we'll be discussing it. Dr. Bhavani.
A very good afternoon to all. The title of the study that I shall be presenting is Hysteroscopy Before In Vitro Fertilization, a multi-center randomized control trial, the INSIGHT trial, which was published in The Lancet in April 2016. Hysteroscopy is thought to improve pregnancy rates in women scheduled for IVF through detection and surgical removal of uterine cavity abnormalities, dilatation of the cervical canal to allow future embryo transfer, or induction of an inflammatory reaction of the endometrium by the procedure itself. In clinical practice, hysteroscopy is often done routinely in infertile women scheduled for their first IVF cycle. The objective of this study was to assess whether routine hysteroscopy before first IVF treatment cycle affects the live birth rate. This was a multi-center randomized control trial conducted by the Dutch Consortium for Research in Women's Health in 7 university hospitals and 15 large general hospitals of Netherlands. Participants were infertile women scheduled to start their first IVF or ICSI treatment with a normal 2D transvaginal ultrasound of the uterine cavity. Women with history of 2 or more miscarriages or intermenstrual bleeding, and those who had undergone hysteroscopy previously were excluded. Randomization was done in a web-based manner by block randomization, and participants were assigned to hysteroscopy followed by IVF group or to immediate IVF group in a 1:1 ratio. Because of the nature of intervention, they could not mask the participants, doctors, or outcome assessors to the assigned group. Women assigned to the intervention group were scheduled for hysteroscopy in the early to mid-follicular phase of the cycle in an outpatient setting without anesthesia, 1 to 3 months before the start of IVF. Paracervical block was offered in case of patient intolerance. The surgeon inspected the endocervical canal, the endometrial lining of the cavity, and the tubulostia, and recorded all findings in a standardized manner. Intrauterine abnormalities were defined as the presence of polyps, myoma, adhesions, or uterine malformations. All participating centers received instructions for the hysteroscopy procedures, including images of intrauterine abnormalities before the start of the study. Therapeutic hysteroscopy was done in the same session if intrauterine abnormalities were detected, or postponed to a setting with anesthesia if necessary. The need for septal resection in a subsequent session was at the judgment of the gynecologists. Hysteroscopies were done by a maximum of 2 gynecologists per center. All randomized women were scheduled for IVF. No other treatment strategies were provided as a part of the study after multiple failed IVF cycles other than repeating the procedure due to insufficient evidence. Pregnancy test was done 14 days after fresh or frozen transfer. Women with a positive pregnancy test were scheduled for a transvaginal ultrasound at 7 weeks and then between 10 to 12 weeks. Women were contacted through a questionnaire or telephonically if the pregnancy outcome was not available from the clinical records. The primary outcome measure that was assessed was ongoing pregnancy rates, defined as presence of cardiac activity at more than 12 weeks of gestation within 18 months of randomization, and resulting in live birth, defined as delivery of a live fetus after 24 weeks of gestation. The secondary outcomes were implantation rate and miscarriage rate per transfer within 18 months of randomization, and the prevalence of intrauterine abnormalities. So 750 women in total were randomized. 373 were randomly assigned to the hysteroscopy before IVF group, and 377 to the immediate IVF group. So from the hysteroscopy group, 4 were excluded as 1 had a previous hysteroscopy, 2 had intracavitary abnormalities, 1 withdrew consent. So out of 373, 369 were included in the analysis for the primary endpoint. Out of this, 325 received the assigned intervention, and whereas 44 received no hysteroscopy. So out of these 44, 13 became pregnant before hysteroscopy, 11 had planning problems, 6 had personal issues, 5 had a fear of hysteroscopy, 2 did not attend, for 2 relationships ended, and for 5 reasons were unknown. And out of the 325 that underwent hysteroscopy, 5 became pregnant before the start of IVF treatment. And finally, 355 completed 18 months of follow-up. As out of the 369, 14 did not complete 18 months of follow-up. Out of the 377 randomly assigned to the immediate start of IVF group, 4 were excluded, 1 had an egg donation, 3 withdrew consent. So ultimately 373 were included in the analysis for the primary endpoint. 364 received the assigned intervention, whereas 9 had to receive hysteroscopy during the follow-up period, 3 due to ultrasound suggestive of a pathology, 2 requested hysteroscopy, 1 had a difficult embryo transfer, 1 had recurrent implantation failure, 1 had a recurrent miscarriage, and 1 had a suspected abnormal cervix. And out of the 364, 12 patients became pregnant before starting IVF. And after after the 20 patients which could not complete 18 months follow-up, ultimately 353 patients completed the 18 months of follow-up. So on analyzing the baseline characteristics, it was comparable between the 2 groups, except that the incidence of smoking was slightly higher in the immediate IVF group. 325 out of 369 women, that is 88% women in the assigned to the hysteroscopy group ultimately underwent hysteroscopy. Hysteroscopy procedure was not completed in 29 women due to pain or difficult passage of the internal os. 2 of these women received a paracervical block. All 29 women were offered a second hysteroscopy under general anesthesia if the initial procedure failed, but it was declined by 28 of them. Women's reasons from refraining from a second hysteroscopy were that they did not want to further delay their IVF treatment or were reluctant to undergo general anesthesia. 43 abnormalities in 37 women were detected, out of which 31 abnormalities were treated. Septal resection was done in 1 woman, whereas in the other 5, after discussion, it was not done. 1 patient with a polyp located near in the tubal orifice was not treated because it was too painful, and she refused general anesthesia thereafter. 2 women with myomas, one with grade 1 and the other with grade 2, did not have treatment due to technical difficulties. On comparing the outcomes between the hysteroscopy group and the immediate IVF group, the primary outcome, that is the ongoing pregnancy resulting in live birth at 18 months follow-up, was similar between the 2 groups. 57% in the hysteroscopy group versus 54% in the immediate IVF group, and the difference was not statistically significant. Similarly, all the other outcomes, whether of ongoing pregnancy, multiple pregnancy, even the time to pregnancy leading to live birth, was similar between the 2 groups. On analyzing the pregnancy outcomes per embryo transfer also, it was seen that the implantation rate, the clinical pregnancy rate, the ongoing pregnancy, and the live birth rate was similar between the 2 groups. The biochemical pregnancy loss rate was significantly higher in the hysteroscopy group, whereas the clinical miscarriage rate was similar. A post hoc analysis was done. All women assigned to the hysteroscopy group who completed hysteroscopy before starting IVF, and those assigned to the IVF group who started IVF without previous hysteroscopy were included. And women who conceived spontaneously in the waiting period, and women who received hysteroscopy during the 18 months of follow-up in the immediate IVF group were excluded. So even in this post hoc analysis, the results of the live birth rate were comparable between the two groups. Of the women who successfully completed hysteroscopy in the hysteroscopy group, 16 out of 25 women with treated abnormalities, 7 out of 12 women with untreated abnormalities, and 143 out of 259 women with normal hysteroscopy had similar ongoing pregnancy rates resulting in a live birth. They assess that whether the treatment of abnormalities would change the primary outcome. Had all the 12 women with untreated abnormalities had a live birth, the groups would still not differ significantly for the rate of ongoing pregnancy resulting in a live birth. So findings from this RCT shows that hysteroscopy does not improve live birth rates in women with a normal transvaginal ultrasound of the uterine cavity who are scheduled for their first IVF. Cumulative rates of pregnancy leading to a live birth and the time to this pregnancy also did not differ between the two groups. Baseline characters were balanced between the groups, except that more women in the immediate IVF group were smokers. This discrepancy seems to not have affected the study outcome because no difference in IVF treatment characteristics were present. Also, a negative effect of smoking on the pregnancy rate would have only further led to the equalization of the pregnancy outcomes between the two groups. Biochemical pregnancy loss rate was more frequent in the hysteroscopy group. It could be speculated that hysteroscopy might slightly improve conditions of implantation, allowing less vital embryos to implant, resulting in a biochemical pregnancy with rapid loss weeks thereafter. However, this pro-implantation effect of hysteroscopy would be expected to be the strongest in the first cycle after hysteroscopy. But no difference in the pregnancy loss rate was found in the first IVF treatment cycle. Therefore, the overall increased pregnancy loss rate in the hysteroscopy group might be a chance finding. In the study, intrauterine abnormalities were detected at hysteroscopy in 12% of women without abnormalities being seen on ultrasound. So these abnormalities detected seemed small and therefore could have remained undetected on ultrasound. The strength of this study was that it's a multi-center design allowing generalization of findings to both academic and non-academic hospitals. It is the first study to investigate hysteroscopy before the start of first IVF with a follow-up period of 18 months, ensuring that possible beneficial effects of hysteroscopy on live birth after several exposures to replaced embryos can be observed. The limitations were that hysteroscopy was done by different gynecologists in many centers, which may be associated with a considerable degree of inter-observer variation. However, to minimize this, all participating centers were given instructions for hysteroscopy procedures, including images of intrauterine pathology before the study started. Another limitation could be that 44 women did not receive the assigned hysteroscopy in the intervention group, which could lead to uncertainty about the true absence of an effect of hysteroscopy on live birth rate. However, the per protocol analysis also showed similar results to the intention to treat analysis. 8 women with treatable abnormalities were not operated upon. However, it is unlikely that this affected the study results because 3 of these women had a live birth, and the primary outcome would still not differ significantly had the 5 untreated women also become pregnant. So routine hysteroscopy, so the conclusion of this study was that routine hysteroscopy does not improve live birth rates in infertile women with a normal transvaginal ultrasound of the uterine cavity scheduled for a first IVF treatment, and women with a normal transvaginal ultrasound should not be offered routine hysteroscopy before the first IVF cycle. Thank you.
So you're muted.
Yeah, you can go on. We 3 can give inputs. 7 minutes left. Yeah, go on.
Okay, so Bhavani, it's good to see you here. What, according to you, are the key features of a randomized control trial?
Ma'am, the key features is the population selection, the allocation, how what method of randomization has been used, whether there is any bias or not, either during selection or during the procedure or during the detection of the outcomes.
Anything else?
Yeah.
So what was the hypothesis in this study?
Ma'am, the hypothesis was that routinely hysteroscopies were being done before the first IVF, considering that 2D ultrasound could miss certain intrauterine abnormalities, which could affect the pregnancy outcomes if not treated. And thus, hysteroscopy was considered a must before IVF to correct those abnormalities, as it was thought that that would improve the pregnancy outcomes. So to evaluate that hypothesis, this study was done.
Okay.
But yeah, this is a very nice study, and they followed very meticulously the consort flow. The consort flow was, the way of reporting a clinical trial was very meticulously followed. Of course, as you said in your presentation, that masking could not be done because it's a surgical procedure. So you can't give something like a placebo or do something, you can't mask it, obviously. And the type of randomization is a block randomization, and they took multiple blocks, which if you have gone through the, if you go through carefully the study, they took multiple blocks where the chance of, the allocation concealment must be carefully taken care of, and there is no selection bias or the ascertainment bias was adequately taken care of. Okay, then if you think about if you compare the pregnancy rates, they're all going to be the same, and beautifully the intention to treat and per protocol analysis, they almost, they yielded the same results with respect to pregnancy rate, which is very crucial. So whenever you're going to look at the bias in an RCT, you need to look at the intention to treat analysis and the per protocol analysis. So what factors bias this, what factors bias? Some biases will affect only the per protocol. They won't affect the intention to treat. So they're both the same. So assume that the biases would have been very, very less. So yeah, I can accept that probably with which is this really has increased a lot of insight about the pre-IVF hysteroscopy among all the clinicians who are anxious to do hysteroscopies routinely before IVF in a general group of IVF population. But it can't, we can't carry these conclusions forward and say that you can just leave off the abnormalities. Like the abnormalities found in the study are very few to draw conclusions that even if there are abnormalities, they don't affect the pregnancy rates is not the conclusion which we have to carry, which we have to look at very carefully. In a general group of IVF population, when the transvaginal ultrasound is normal, you don't have to put a scope and make out the abnormalities. The little abnormalities which we're going to miss doesn't matter. A general group of IVF population doesn't affect the live birth rates, but doesn't mean that the abnormalities, even if they are there, they don't matter. It doesn't mean the conclusion should not be taken in that way. I think these are only my observations in this study. If anything else, maybe Dr. Mohan Kamath sir should throw a broader light into this.
No, I think I'm just going to sum it up because we need to move to the next speaker. It's actually, if I rate it, Bhavani, what would you rate it out of a scale of 10? 8 or 9 out of 10 or 7? Where?
So 9 out of 10.
Okay, you've been liberal. I'll also be there. 8 or 9 out of 10. A few things, because these are what we are trying to build on. So randomization, concealment, everything is there. It's a web-based randomization. Also, you have to always quote whether it was prospectively registered one. Then how do you make out something like selective reporting, which is like people add on new outcomes which were not originally planned. Like if you go back to the ERA study now, and which has been the randomized trial published recently in RBM a couple of years back. So the one of the criticism was they have included cumulative live birth as a retrospectively. It was not planned. Okay, so this is something like people do. You can't change goalposts once the study is over. Okay, so that's why selective reporting is not there. Then there is something called attrition bias, which is basically if they have not taken into account the lot of dropouts. Okay, now having said all this, most of these things have been planned and analyzed in cancer trials. Okay, so where there is a lot of dropouts because of side effects and so on, it can really make it very difficult for us to assess the effectiveness of a intervention. So remember that. The other point probably I just want to highlight is one of the controversies of this trial was in the Dutch, the Netherlands, I think septal resection is not offered upfront. Okay, and so they left behind somebody who had septum, which is kept as a, people were not very happy with that, though they have gone on and done the trust trial and so on and so forth. The answer is still unambiguous for them. Whereas for us, it will be very difficult to say, let's leave a septum behind before IVF. So those are the things, but I would probably touch upon these again during the next couple of presentations. Otherwise, thank you. Thank you very much for the presentation. Yeah.
Thank you.
Any doubts that anybody has, delegates on this trial? We can take one question, or anybody wants to add something. They can put it in the chat box and we can keep taking it up. I'll request Dr. Anupama Madam to take the next student. Yeah.
Okay, so the next student is Dr. Sharmishta Sarkar from CMC Vellore, and she will present her study on pregnancy outcome after office microhysteroscopy in women with unexplained infertility. Dr. Sharmishta.
And before Sharmishta starts, I'll just add a point, Dr. Bhavani, that this particular study was categorized as a low risk of bias for all the outcomes that we are looking at. So if you go to the Cochrane review on screening hysteroscopy, it was categorized, all the domains were categorized under low risk. So that's the important point that needs to be taken away. Okay, thank you.
Okay, sir.
Good afternoon, respected consultants and my dear colleagues. Today I'm going to move on to the second topic, that is pregnancy outcome after office microhysteroscopy in women with unexplained infertility. This article was published in International Journal of Fertility Sterility in 2015. It is a peer-reviewed journal of Israel, and this trial was conducted in Egypt, mainly in the Department of Obs and Gynae, Al Fahim General Hospital. Hysteroscopy is the gold standard for diagnosis and treatment of uterine cavity pathology. With advent of smaller diameter hysteroscopy, the need for anesthesia and patient discomfort can be circumvented. The objective of the study was to evaluate microhysteroscope findings in unexplained infertility, to see the pregnancy outcomes following therapeutic procedures in the office microhysteroscope group. Pregnancy outcomes were followed over the 12-month period between the two groups and compared, and also they went on to see the patient compliance in the office microhysteroscope group. It was a randomized controlled trial conducted in Arafah Hospital, Egypt from 2006 to 2013. They had included 200 infertile women who were previously diagnosed as unexplained infertility. They had randomized the women using a computer software. The study group had 100 women, and that was in the office microhysteroscope group, and the control group, 100 women, they did not undergo any intervention. Institutional ethical board approval was obtained. Transvaginal ultrasound was done before starting the office microhysteroscope in the study group. It was performed in the early post-menstrual period. They had used 2 mm fiber optic microhysteroscope, and if any abnormality or pathology was detected, surgery was performed in the same sitting. Patient also had received oral pre-medications or IM diclofenac and conscious sedation with fentanyl if severe pain was there. They also had paracervical block with lignocaine. They, after showing the baseline characteristics, they said it was not statistically significant, though they did not put any p-value. They went on to show the results. In the results, in group A, that is those who underwent the office microhysteroscope, they say that 28.5% of the women had pathologies detected. And they also, in this pathologies detected, endometrial polyps was 20%, submucous fibroid was 3%, adhesions 3%, polypoidal endometrium 3%, and bicornate uterus 1%, and 70% were women were with normal finding. Later on, they went on to see in this 1-year follow-up period, the cumulative pregnancy rate and ongoing pregnancy rate in these women who were treated. Then in the group B, that is who did not undergo any procedure, did not undergo hysteroscope, the cumulative pregnancy rate in them, they said it was 15% and ongoing pregnancy rate was 10%. They also saw the patient compliance during and after the office microhysteroscope. 90% did not have any discomfort or had minor discomfort, 5% had discomfort, 3% major discomfort. They also went on to see the pathologies in relation to the woman age. In their discussion part, they have said or quoted that it compares with HSG, that HSG misses 35% of the uterine pathologies. It will not allow simultaneous correction in the same sitting, and it is less costly compared to the office microhysteroscope group. 30% of the patients undergoing office microhysteroscope had uterine pathology in their study. It was around 28%. They said it was a safe procedure, and the treatment of pathology and irrigation of the cavity with saline, they said it may have beneficial effect on implantation and pregnancy rate. So to summarize, they say the pathology is present in 20 to 50% of the infertile patient, and it is recommended thus to do hysteroscopy as a part of infertile workup as the first line infertile workup instead of doing HSG, with a routine laparoscopy and dye test also. Little bit I'll go on to the critical analysis of this article. First, starting with the title, there was this randomization in the title is a requirement in the consort checklist of RCTs, which was not there in this study. Then moving on to the introduction, they have quoted in the first paragraph that hysteroscopy is only recommended by WHO when clinical and complementary examinations are suggestive of intrauterine abnormality or after IVF. But there is no such recommendation by WHO, and it was not, the referencing was also not mentioned. Then in the introduction, they did not specify the objectives or hypothesis of the study. The objectives were not mentioned clearly. What were they going to look for? In the methodology group, there was a lot of, in this section, there was a lot of faults. The primary and secondary outcomes were not mentioned. The outcomes were not predefined. The sample size, they had taken 200, but how the sample size calculation was done, they had not mentioned. Whether any previous study was taken, they have not mentioned. There was no detail about the method of randomization, whether block randomization or permuted randomization, it was not mentioned. They did not mention about the allocation concealment, whether any envelope was used or not, they did not mention. The inclusion exclusion criteria was also not mentioned. And they did not mention about any blinding, though blinding would not affect the outcome. It was not registered trial also. Whether it was funded or not by the microhysteroscope group, that also they did not mention. And who performed the baseline USG, because before starting the microhysteroscope, they say that they did a baseline USG to see those without any abnormality had undergone the microhysteroscope. But there may be inter-observer variation. And in the results also, they did not provide consort diagram. So we don't know that if any patients, if any, how come 100 of the patients recruited, all outcomes were assessed. P-value was not given in the baseline characteristics, though they had mentioned in a paragraph that it was not statistically significant, but the P-value they did not mention. Then we also see there was the selective reporting of outcomes like clinical pregnancy rate and cumulative pregnancy rate and ongoing pregnancy rate was more. So they reported only these outcomes. Live birth rate was not looked at. It was not looked at in this study, though they said the study duration was of 7 years. Then they said in a paragraph that none of the office microhysteroscope group had aborted, but we saw in that table that the cumulative pregnancy rate was 28.5% and ongoing pregnancy rate was 21.5%. That was in 1 year follow-up period. So if there was no abortion, then how come cumulative pregnancy rate be more than the ongoing pregnancy rate? Then the in the results table, the distribution of different pathologies, it was given as percentages. Cumulative pregnancy rate was given as percentage, ongoing pregnancy rate was given as percentage, but there was no p-value put in the table, so we don't know whether it was statistically significant. Then they also gave a table in relation to age of different uterine pathologies. We don't know why they put that table, because it has no significance. Then in the discussion part, the strength and limitations of the trial are not mentioned. So this is like in the selection bias, random sequence generation was not mentioned, so it was of unclear bias. Then allocation concealment not mentioned, unclear bias. Performance bias, it was not mentioned, but it would not have any effect on the outcome, so we can avoid this. Then detection bias also, it would not have any effect on outcome, so we can avoid this. Attrition bias, they said 100 women had followed up, so this is good. Then reporting bias, there was selective reporting. We can clearly see that they had only reported on cumulative pregnancy rate and ongoing, and not on the live birth rate. Thank you.
Very well presented, Dr. Sharmisha. You've left absolutely no scope for questions. You've summed it up very well. So how would you rate this study?
Ma'am, less than 5.
I think I would rate it as 4 on 10. So what about you, Dr. Mohan?
I'll mute. Sharmisha, good work. I didn't tutor her, but she's probably done a pretty good job. That's one thing. So yes, I would agree with Madam here. It's I will not rate it pretty high. It's less than 5. And I think she's gone through the systematic review as well. So a couple of points, let's just discuss this. Why do you think baseline table was not mentioned and it should worry us? Anything that
sir,
you can
baseline
add?
table was mentioned, but they didn't put the p-value.
Yeah, but was the table given for baseline variables?
Yes, sir, table was given, sir.
Okay, so is it equally distributed? Did you comment on that?
Yes, sir, it was almost equally distributed.
Okay, so the thing is, what I want to stress here is baseline variable tables are very important. Randomized trials, even though we assume that the variables and prognostic factors will equally get distributed, this doesn't happen very often, and there will be some differences in the way the control and treatment group is, and this is not seriously taken as much. It's a randomized trial, so everybody assumes that they start equal, but that's not the case. In fact, now on retrospect, when I think about the INSIGHT trial also, if you look at it, they have only presented the risk ratio, that's a crude risk ratio, whereas nowadays, if you look at landmark trials and all, they even then also go ahead and adjust the risk ratio for the prognostic variables. Okay, so it is not correct to assume that in a RCT the baseline variables are almost similar and we don't have to worry about it. I really scrutinize the RCTs for the baseline variables because it gives you a lot of clues. It also tells us whether the population is what we are looking at is it's got the sampling has been correct or not. You might have some units which will have a very different group of patients. So baseline variable tables, my one limited message is, even in RCTs, you need to look at it very carefully. And in the other biases section in the risk of bias, we look at this because sometimes the baseline variables are simply untenable, whatever has been given by the author. So something that all us need to probably look back, because these are the tables which we skip very routinely and we just jump to the result section, which should not be done. The youngsters should start focusing on this particular thing. Other thing, obviously no sample size, and you can't have a situation where 100 patients were randomized and all completed the trial. So these kind of, if people commit it on during peer review, then as a reviewer, I will be really skeptical about the findings. Okay. So if you just look at the larger question, we started with the research question and we are no better even after the study. You are not going to change practice. That's the limited point. That's all from my side.
So and one more thing to go to a little scientific aspect of it, because it's related to our reproductive medicine. They didn't define the population in the study very well. They just said unexplained infertility. They didn't define unexplained infertility. What is their definition in the study? We all know the definitions of unexplained infertility, but when you're doing an RCT, it should be defined. And not that unexplained infertility with previously treated, previously undergone, what treatment they have undergone, or they have taken only naive patients just diagnosed unexplained infertility, or how many years they have been actually trying fertility. These are all, will indicate definitely a heterogeneous, can create a bias in the selection group is not clearly defined. And that's one of the major thing. And when you compare the INSIGHT trial and this, and of course the objectives are different, but the sample size is very meticulously given in the INSIGHT trial. And there's nothing, how the miraculous number 100 they land upon is definitely, it's really, we can't justify that in any way.
How many comments, final comments for the study?
I think it's all been covered very well. So the primary endpoint has not been defined. The entire study is flawed, I feel. You can't have a study where, everybody just comes in and goes out and everything is very hunky-dory. So yeah, I won't really rate it much.
I think the two studies have shown us the stark differences between the quality. That's what we are trying to send the message across. That look at, both are supposedly randomized trials and both have made their way through in the systematic review on screening hysteroscopy. This is slightly different population. This was probably the only trial for unexplained infertility, whereas all the other trials were for IVF. But just look at the difference and all. And I was one of the authors here, and we had discussion on whether to downgrade the study because they did not report live birth rate where they were in actually a position to. And that's why in selective reporting, it was downgraded to high risk. If you go back to the Cochrane, they have actually, they did not commit in the protocol stage. There was no protocol stage, but it was factored in that it was a 7-year-old long study. And if anybody wants to do it, she would have clearly got the live birth rate while publishing. So that's why it was downgraded for selective reporting. That's a limited point. I think that's from all. I think we can move to the next. Thank you, Sharmishta.
Thank you, sir. Thank you, ma'am.
Okay, thank you. I will just call upon the third student. So she's Dr. Ritam Kumari. She's from UCMS New Delhi, and she will present her study, and we will then probably critique it. Yeah. Dr. Ritam, you're there. You can share the slides.
Hello.
Yes.
Good afternoon, everyone. Sir, I'm unable to get that share option on my screen.
Varun, can you help her out? Ritam Rajan is the name they are showing.
Yes, sir, I'm getting now.
Yeah, please.
So, good afternoon, everyone. I'll be presenting a study. Hello.
Yeah.
I'm presenting a study titled Effect of Antenatal Steroids on Respiratory Mobility.
Sorry, your slides are still not on.
Okay.
Are you able to share it? Yeah.
Now, is it visible, sir?
Yes, yes. Yeah, please go on. Yeah.
So my study that I'll be presenting is Effect of Antenatal Steroids on Respiratory Mobility of Late Preterm Newborns. This is a randomized controlled trial. It was conducted by Vijaya Ontela et al. In Jawaharlal Nehru Institute of Postgraduate Medical Education and Research, JIPMER, India, and it was published in Journal of Tropical Pediatrics, 22nd of January 2018. Preterm birth is defined as any birth at less than 37 completed weeks of gestation or fewer than 259 days since the first day of woman's last menstrual period. It is further subdivided on the basis of gestational age, like extremely preterm, that is less than 28 weeks, very preterm, that is 28 to 32 weeks, and late preterm, that is 32 to less than 37 weeks. The global prevalence of preterm birth is 9.6%, with incidence of preterm birth in India being 13%. Preterm birth constitutes 14% of all deliveries of India. Late preterm infants are at higher risk of adverse respiratory outcome compared with term infants. The benefit of antenatal corticosteroid before 34 weeks is well established, whereas the effect of antenatal corticosteroids in the preterm infant, late preterm infants is still debatable. So the objective of the study was to study the effect of antenatal dexamethasone on the respiratory mobility of late preterm newborn. It was a randomized controlled trial. There was 155 participants in each study and control group. It was conducted between February 2015 to June 2016. It was conducted in JIPMER, India. The inclusion criteria being women admitted in labor room with a period of gestation between 34 and 36 plus 6 weeks of gestation with a singleton pregnancy, and those who are at risk of preterm delivery either spontaneously or requiring termination for maternal or fetal indication. The exclusion criteria were those who were more than 5 centimeter dilated, received previous course of steroids, chorioamnionitis at admission, multiple gestations, gestational diabetes and diabetes mellitus, major congenital malformations, and those undergoing a pre-labor scheduled cesarean section. Randomization was done into antenatal corticosteroids group and non-antenatal corticosteroids group using computer-generated random numbers. It was generated and provided in a sequentially numbered sealed opaque envelopes from an independent data coordinating party from the Department of Preventive and Social Medicine from the same college. They gave 6 milligrams of dexamethasone, 4 doses, 12 hours apart to the study population group, and no steroids or no placebo was given to the control group. They screened 1,575 females, and on the basis of inclusion and exclusion criteria, only 310 were selected, and they allocated them into study group and control group. In the study group, 108 females completed the full course of steroids, and others received 1, 2, or 3 doses and could not complete the complete course. There was no loss to follow-up, and all of them delivered before 37 weeks, both in control and study group. In the study group, they analyzed only 154 females because one of them had stillborn baby. And in the control group, they analyzed 155 females. Their primary outcome were composite respiratory mobility, that is transient tachypnea of newborn or respiratory distress syndrome among newborns. The secondary outcome being hypoglycemia, hypothermia, poor feeding, sepsis, neonatal mortality. Coming to their results, they found that in study group, 51 subjects had transient tachypnea of newborn, and in control group, 46 had transient tachypnea of newborn, the relative risk being 1.12, but this was not statistically significant. Similarly, respiratory distress syndrome was in 13 cases in study group and 10 cases in control group, with relative risk being 1.31, and this was also not found to be statistically significant. And composite respiratory morbidity, that is TTN plus RDS, was found in 64 cases in study group and control group 56 cases. The relative risk was 1.15 and the p-value was 0.32. That is, this is also not found to be statistically significant. To remove the bias due to multiple confounding factors like mode of delivery, birth weight, and period of gestation, they also conducted a multivariable analysis. And also they conducted both intention to treat and per protocol analysis. But in both the analysis, they found that there is no statistically significant reduction in the steroid group in composite respiratory morbidity or transient tachypnea of newborn or respiratory distress syndrome. Coming to the discussion, they found that there is no statistically significant difference was observed in respiratory morbidity. And similar observation was also given by Porto et al. In their study also, they did not found any significant difference in respiratory morbidity, transient tachypnea of newborn, and respiratory distress syndrome among the steroid group. But in their study, 78% had completed the steroid dose. However, 43 women were lost to follow-up. But in Balsi et al., a study conducted by them, they found a significant reduction in the respiratory morbidity among late preterm infants after use of antenatal corticosteroid. The strength of the study was 68% of the study group received complete course of steroid. And also they tried to remove multiple confounding factors like multiple gestational, maternal diabetes mellitus, measles congenital malformations, and also they excluded the pre-labor planned cesarean section. The limitations of the study were this study did not have a placebo group, means the placebo group, the control group did not receive any drug, neither the steroids nor any placebo drug. And also the enrollment and allocation to the intervention were done by the same author, which could be a source of bias. Thank you.
I just want to know, was this trial registered in CTRI?
Yes, ma'am. This was registered in CTRI.
Okay.
Yeah. So reasonably, they've done made an attempt to do a trial on a CT rather, but the group of patients who are at risk of preterm, that's a very vague way of defining a study population. Patient at what risk of preterm, what they mean that there is a risk of preterm, that should have been very much specified. And you have very much clearly pointed out that there's definitely when there is the same person is involved in the randomization, there should be a third party who should be involved in randomization, not the none of the persons were involved in the trial. So that wasn't followed. And of course, a placebo would have been a way of masking, which is reasonably possible, which they have not followed up. And they have taken care of doing the intention to treat analysis by adjusting the baseline characteristics, which have shown some significance in the baseline evaluation, the baseline characteristics, which is a very good in analyzing. So further, Dr. Mohan sir, or
it's a reasonably well conducted one. So it is prospectively registered, is it?
Yeah, it is registered.
Yes, sir. It was registered.
Okay. Now, what was the sample size based on?
So it was actually based on the previous studies which were conducted, and it was done after taking care of the power, 80% power in alpha error of 0.05%.
I know, but what was the primary? It is sample size is usually based on the primary outcome and what difference we are looking at. So what was the difference here? What we found between the two studies, control group and the incidence of composite outcome? Can you just read? What is the final complication rates in that table? The previous one, I think. The absolute numbers. Yeah. So see, you'll have to go back and check what was the difference that we're looking at for the in the sample size calculation, because sometimes not this study, this might be a good study and all, but there are certain times that we overestimate the possible benefit, that is something like if we say the difference is going to be 20% and all, like in IVF and all, many times people take up one study and use that, and then we say we might expect a benefit of 20%. Any comments? If you take a very large difference expected, how does it matter in the trial? So suppose the investigator decide that the previous study has shown benefit of 10%, but the investigators decide,
they have taken, it showed a significant difference of 25%. On that study, they decided the sample size.
Yeah, so 25% was the difference, which is quite huge, and that's why the difference, the sample size has come down. So typically, that is something we'll have to see why other studies found that much difference and why this study did not find any particular.
The author
reason?
expected a 50% reduction. That's what he has. A 50% reduction is expected with intervention.
Yeah, so that is why probably in these kind of cases where it's a negative study, I would probably go back and see what is the difference between this study and the previous studies, which is quite something that needs to be investigated, because there could be some difference in the sample population. I'm not privy to the previous studies and why they were so different from this study. That's something that we need to look at. That's one thing. And yes, I think there is a case to probably look at a placebo controlled trial, because awareness from the both participant, but more importantly the clinician, that the lady has received steroids could probably influence our behavior in her management.
Yes.
Okay. The either ways, if the patient hasn't received corticosteroids also, you'll be a little there is a possibility that you might behave differently in your management. That is what differs, and that is, there are two aspects to it. When it's masking or blinding is not done, there is something called performance bias. That is the clinician's behavior or the patient's behavior, or there is something called detection bias. That is how the outcomes are being assessed. And if in this case, there is, you can say it is more of a, I don't know, you will say it's a subjective outcome. It's more of a objective outcome, isn't it?
Objective outcome, yes.
Yeah. So I would still not worry so much about detection bias. Okay. That is because I feel that the baby, the way it is being diagnosed, there won't be much difference whether you know it or you don't know the allocation. But definitely there is a possibility of performance bias. So this is a very important point that everybody needs to remember, that blinding can affect at two levels. One is performance bias and one is detection bias. So these things are now split. When you look at a review nowadays, you will see we might, for lack of blinding, we might put a study at a low risk for detection bias, but we might still put it for high risk for performance bias. Okay, so these are just a little more. If you go in deeper, these differences might come in for the same fact, that is lack of blinding. Okay, that's the limited point. So yes, I would also agree that the placebo would have been, it wouldn't have been that much of an issue in terms of ethics when they have already put it as a control. So that's where I would say, yeah. I would stop here. Any comments from anybody in terms of anything else to add?
So what I feel is that the trial is tilted towards the control group. Like if you look at the results, TTN, RDS, everything is more in the study group, in the subjects who have received steroids.
Yeah.
So could there be a bias in that? Or could they have done a subgroup analysis, but
Yeah, I would say this is just by chance that they have got a little more of this. I won't worry too much about it. Essentially, all I can say at this stage with this results is, I would say, is that there's no difference between the two groups. Slightly higher and all, it could be just a random chance. So I would not stick my neck out there. I would just stop there, that this is not showing difference as we would have expected to, and we'll stop at that. I think they've also adjusted for something, and risk ratio, I saw that figure. Can you just show the next slide?
The next slide had it.
Yeah.
Yes, please.
So you should actually check what was this adjusted for. I could not see. It's just written
Was
relative
it
risk.
the gestational age that it was adjusted for? That would probably make a difference.
Yeah.
And the randomization was done by a third party, which they have mentioned, which where the presenter was pointing out that it was done by the same. It is not so. It's been done by the Department of Prevention and Social Medicine from independent data coordinating party. So not by the, So
I think this point,
in the
yeah, please go on.
limitations part, they have mentioned by themselves only ki allocation and implementation was done by the same author, so there can be bias. This is mentioned in their limitations part only.
Okay. This point I just want to highlight again. This adjustment is a very good thing. Again, highlighting the point that even in randomized trial, you are supposed to adjust for certain prognostic factors, and if it is actually the gestational age, then it's a good thing. Basically,
they have adjusted for everything. Like in LSCS patient, there is always a high risk for respiratory distress if we are considering the late preterm group. So they have adjusted for mode of delivery, birth weight also, and for period of gestation also.
Yeah, so essentially what they are trying to tell us is that risk ratio, predicted risk ratio will change according to if all these were similar at the baseline. Okay, what we got, the crude risk ratio was what the study got. But if you get all your these prognostic factors as same by logistic regression, then you probably will get this adjusted ratio, and which is, as far as I know, at least it is shown significance in LSCS and birth weight. It's lower in birth rate. What is this birth weight? Yeah, all these are adjusted.
Lower in vaginal birth, and it's shown to be higher in LSCS patient.
Yeah. And what about the main outcome? This is the main outcome, isn't it? The steroid, the first one.
So the first one was the main outcome.
Yeah, and that is also not shown significance. So that's what it is. So that's the important thing, essentially, that they have taken pains to, because this was not shown in the INSIGHT trial. That's what the point I was trying to make at that point. That this is something which is routinely done now for very large randomized trials. So it's a good study as for the I consider. Thanks. Okay, thank you very much, Dr. Ritham, for.
If I can just ask you if we can take a minute, because you have been experienced with all the RCTs and systematic reviews. So can you explain a bit about per protocol effect and
see per protocol, what actually is happening is intention to treat is more nearer to the actual situation in real life. That is, if you put a policy in place or policy makers, they are going to go by intention to treat. Because anytime you treat or give a whatever treatment you order or give it to a patient, there'll be many who will not comply. Okay, and even in real life this happens. So the intention to treat is more nearer in real life picture, but per protocol will tell us what exactly is the impact of that treatment. Okay, in if you look at an individual level, because that's only those patients who have complied with the protocol. So if you look at a paper and if you see per protocol results and intent to treat, as a policymaker or somebody who is deciding the unit's protocol, I would go by intention to treat, because that's what it will play out in real life practice. but I just want to know whether this treatment is really working. Little bit clue I will get in per protocol, but there is a catch. The catch is that per protocol, we don't know how the baseline variables have played out.
Yeah.
The baseline variables were played out at intention to treat. That is, they have been randomized at that level. Per protocol, you have not randomized. So you might erroneously say that per protocol, it is showing effect, but actually the baseline variable would have shifted in favor of the treatment. Okay, so that nobody is giving.
Say that the people who have not adherent, the treatment, the intervention may have a different effect on people who are not adherent.
So
equal effect.
So per protocol baseline, nobody is giving you. Everybody is giving you randomized, the first one, that is at intention to treat analysis. So be very careful of interpreting even subgroups. Subgroups also can be skewed either ways, whether they are showing effect or not. So if we don't understand this kind of concepts, it's very, very dangerous to interpret papers, I would say, or the face value. You should never do that. That's the difference. Yeah. Okay, I think that we will close this session. Dr. Anupama Madam, thank you for joining as an expert, and we hope you stay back for us. Your critical inputs are welcome. Thank you, Dr. Siddharth. And I think I'll hand over to, okay, I'll just introduce the next session, sorry. And then I'll let me just see this. I'll introduce our next chairpersons for the next session. The students did fantastic, all three of them. Just to reiterate, I think we've got the message across about the variation in the type of studies. Now that we have this knowledge and information, probably we'll move on to the second session where Varun, can I have the slides, please? Yeah. So we have three chairpersons. And this is Dr. Sangeeta Sharma is here, who is the center head Infertility and IVF Jaipur Fertility Center and a good friend. Dr. Harpreet as well. She is senior consultant gynecologist and reproductive medicine from Chandigarh. She's also very good in research and academics. And Dr. Arvind is the clinical embryologist and reproductive physician from Bloom Fertility, Chennai. So I welcome all the three chairpersons and I request them to take over the session. And this session is basically to run through the main steps of systematic review. I'll let the chairpersons take over. Thank you.
Yeah, thank you so much, Dr. Mohan, for the introduction. And I congratulate you and I congratulate Dr. Uma for this wonderful and actually much needed workshop, because especially in today's era when new interventions are coming, every day we are seeing new interventions in every field, and it becomes very important to understand that on which evidence should we rely on and what are the limitations of each and every study. So that understanding becomes extremely important. And in this session, we would be dealing with systematic reviews, the initial considerations. And the first speaker we have is Dr. Uma Satvik herself. And she's a very good person, a very good friend, and we share memories from the Gangaram days when I was also doing FNB there. And she is actually a consultant there in the Center of IVF and Human Reproduction, Sir Gangaram Hospital. She's the co-convener of IFS Special Interest Group in Research Methodology, and she's a teaching faculty and guide to the FNB, the NB Fellowship students in reproductive medicine, the MET and IFS Fellowship in reproductive medicine students. She is a reviewer of Journal of Human Reproductive Sciences, and she has special interests in research, ovarian physiology, and unexplained infertility, and she has 17 publications in indexed national and international journals. So over to you, Dr. Uma, and she would be speaking on the what, the why, and the who of systematic reviews.
Thank you, Sangeeta. Can you hear me?
Yes, we can.
Thank you. Thank you for joining in, and thank you for that introduction. So the first talk is largely an overview of what systematic reviews are, and I hope I'm able to cover it in the 20 minutes I've given myself. Sangeeta has rightly set the tone for this session that we do know multiple papers are published in Medline, and one number that was in fact stated was that about 1 million biomedical papers would be published annually on Medline. And as per Web of Science, 7.5% of the top cited articles belong to OBGY. So that's a large number of literature that one has to sort through. And if one were to really stay on top of what is coming out in the field, one has to do that kind of reading. Clearly, it's not always possible. And one would want to then know, and especially in the face of knowing that there are two kinds of research types. One is known as primary research. Now, primary research is what will generate primary data, where you are actually individually studying patients, collecting their data, what intervention was done on it, and what outcomes actually show up in these patients based on those interventions. So that is primary data. However, whatever results that one study may produce may be limited by numbers, as we saw in the previous session. It may be limited by settings, and it may be limited by designs. So one might find that one study is saying something and the other study is saying the other thing. So conflicting results, and one does not know where to look really in terms of guidance. Secondary research is the second broad classification of research type, is what will not generate primary data. And it has a high place in medical research. It may be called armchair research by journalism, but this has a high place of pride in medical research, because it puts together primary data from multiple sources in a way which is reliable, which is replicable, and which one can actually use to guide one's practice. And the purpose of this talk is largely to tell you about how and why should we trust these systematic reviews. Purpose of these systematic reviews would be to resolve conflict. So example of secondary research is not just systematic review, but textbook chapters that we would have read are actually a sum total of multiple researchers that have been put together to bring about an overview on a subject, commentaries by an expert in a certain field or on a certain subjects, or commenting on a paper based on one's own knowledge and putting in literature from all over to be able to comment on a paper, whether this is good or bad, and how much to trust on it. There are different kinds of reviews. Reviews is something that we are all aware of. There could be the traditional or the narrative review, the systematic review, which is what this workshop is about, and of course, what is now coming in, which is the scoping review. If we were to look at differences, so just what are systematic reviews? This is a key study design for secondary research. The idea is that it attempts to find an unbiased answer to a specific research question by systematically looking through all available literature. And those are keywords that I've highlighted: unbiased, specific research question, systematic sorting through literature, and this is all available literature, not just what you have access to, but whatever literature would have been published till date. So because of these keywords that have been highlighted, it is more likely to be replicable and more likely to be telling the truth. This is different from a narrative or a traditional review, where the search of literature is not systematic and in fact might be based on very limited sources that one has access to. Also, because the study choice in narrative review or traditional review is not pre-specified based on what criteria one would want to identify these studies to choose. One might just use one's own biases to select these studies. One says that the replicability of these reviews might be low. So somebody writing on, let's say, the usefulness of ICSI in non-male factor, and looking at a very few studies, might say that, oh, this is very useful in non-male factor, whereas another reviewer looking at another set of studies may say it is not useful. So narrative or traditional reviews, if I were to put it in another slide, which follows this slide, but systematic review follows a series of steps. Number one step is looking at a specific research question. We will look at what a specific research question in the subsequent talks, and I'll give you a slight idea in this presentation as well. The second step is building a team. Third is writing a protocol. We saw the importance of what writing protocol is. You don't want to, you have an idea in your head, you have a method to follow that idea in your head, which you write down that this is the question I'm trying to answer. Where I will look for the answers is what you define. So that is known as a clear literature search, where you retrieve literature. Based on this, how will I select studies is what is written in that protocol, and what are the outcomes one is looking for is written in that protocol. So all of this is predefined even before you can start a systematic review. So once this has been written and it has been registered, and the importance of registration has already been mentioned in the previous session as to how you are not allowed to, or if you were changing your intentions or your outcomes later, it would mean that there is something else that you have included in your study methods later based on some new study that you have came across. Retrieve literature is again a very important step. We'll see how this is done in one of the talks that follows mine. Identify relevant studies, critically appraise evidence, synthesize this evidence, and finally you interpret it and give recommendations for practice. So those are the steps in a systematic review, which if followed methodically will yield the same answer no matter where the systematic review is done. Right? So this just brings us back to, I was talking about narrative reviews and systematic reviews. And if we were to use those points, the steps that I mentioned in systematic review to differentiate between narrative, systematic review, and scoping review, you would find that narrative review is the traditional form of review where the research question is broad. It could be specific as well, but mostly it is broad. The protocol has not been written previously. There is no team needed, and it can be written by one expert. There is no systematic literature search. Study screening for eligibility is not done. There's no critical appraisal of studies. Evidence synthesis using scientific methods is not done. And the purpose, where would we still use a narrative review, mostly as part of dissertation or thesis as of now. And however, it's not completely useless because it will give you an overview of a topic if the research question was broad. Systematic reviews, on the other hand, have a specific research question. The protocol has been written previously. There is a team that you already have chosen, and the team members have different skill sets. We'll see what those skill sets will be. Systematic literature search is done, study eligibility criteria defined, critical appraisal of chosen studies is done. And finally, you use scientific methods, statistical methods to try and synthesize evidence in order to come up with one effect measure or one answer. The purpose of systematic review is basically very precise. You're trying to answer a question on whether an intervention works or not, where there already exists a lot of ambiguity, okay, and how much it would work. Also, systematic reviews are what are used for framing practice guidelines by the high bodies of medicine. So it could be ASRM, it could be RCOG. They would be using reviews to frame guidelines, right? Now, scoping review is basically a narrative review. It's like you addresses a broad question, looking at what is the scope of a certain subject, you know, what are the different, so let's say it was ICSI again that one was looking at. So it would start off with looking at all literature that is available. The difference between scoping and narrative review would be that one is doing a systematic literature search even here. One is writing a protocol and one is still looking at a team that could do the systematic literature search for you. But what is the difference between scoping and systematic review? That here the question could be broad. You are not really doing a critical appraisal of included studies, and evidence synthesis is not really possible because you're looking at multiple topics here. So ICSI, let's say you were looking at, you could go and define how it came about. You could define what all are the indications for it, where it is best used, what are the adverse effects, if at all, associated with it, and what are the knowledge gaps. So scoping review would largely have replaced a narrative review because the literature search is much more comprehensive in a scoping review. And it will help to answer questions of whether or not, if there are any knowledge gaps pertaining to a certain subject. And this might be the stepping stone for undertaking another systematic review, which has a specific question. Okay, so now the question is, what is a specific research question? First, let us look at what is a non-specific research question. The first one would be, what are the ways to improve IVF results? There could be several. It could have to do with patient factors, stimulation factors. It could have to do with embryology factors. And however, if a specific question could look like this: does universal ICSI lead to improvement in live births in non-male factor infertility? Why is this specific? Because we have a population defined, non-male factor infertility we are looking at. There is an intervention that is defined. A comparator could be where ICSI was not done in such cases, and the outcome has been defined here. So where the PICO is defined, we call it a specific research question. Consider this title: Agents for Ovarian Stimulation for Intrauterine Insemination in Ovulatory Women with Infertility. Now here we know that the population is defined. It's ovulatory women with infertility undergoing intrauterine insemination. And we are looking at whether one agent or the other that are used for ovarian stimulation would be better or not. Okay, but the ovarian stimulation agents we know are several, and comparing one with the other might mean that we might have several combinations that is possible. And outcomes, because in IUI, it's not just live birth, there are some adverse effects which are also associated specifically with IUI, not so much with IVF as we practice it now. Because IUI, you may have no control over multiple pregnancies or OHSS in at-risk women. Those are also outcomes of interest. So those are the three outcomes. If you are looking at so many interventions and so many outcomes, even a title like this is still can have multiple sub-PICOs. So one of the sub-PICO could be aromatase inhibitors versus anti-estrogens in ovulatory women undergoing IUI in determining live births, or it could be gonadotropins versus anti-estrogens in ovulatory women undergoing IUI and determining multiple pregnancies. Okay, so you could have sub-PICOs, and it is entirely the job of the primary investigator and the subject expert to try and identify the PICOs that might be relevant to the topic that has been chosen, right? So one SR can have multiple PICOs. Who can do it? Building a team. Well, I've already written, one would need differing skill sets. And if you remember the steps that are undertaken in a systematic review, one would need at least two subject experts, right? One of the subject experts is the one who's posing the research question after doing an extensive literature search, looking for knowledge gaps, seeing ambiguity in literature, has devised this research question, has written the protocol, has devised inclusion and exclusion criteria. And once the studies have been given back to you by the search expert, reviews the studies to see which ones to be included, and finally extracts the data. At least, and why do you need two? Because independently, if two are doing it, bias of one subject expert can be overcome by the presence of the second subject expert. Second kind of skills that are needed is that of a search expert. Who's a search expert? Usually an information specialist or a librarian who is capable of looking at keywords. And this is a very complex task. It's not something that one can do without some basic level of training. To look at, to put it out there, look at all databases, and then finally devise a search strategy to be able to look at every possible published literature that exists on all the databases. And this is extremely, I would say, a very skillful job. Number three is a statistical expert. You need at least one, and you'd be seeing that some of these terms that we'll be using, meta-analysis, which is a statistical method to synthesize quantitative data. Sensitivity analysis, which is a method to try and look at alternative scenarios in a clinical situation, that if this was the scene, what would the results have been like? Forest plots is again a way to visually express the results of a systematic review, and funnel plots, which are a way of assessing whether there are publication bias in your systematic review. So all of this could sometimes be jargon to us, and also the nitty-gritties of how to thrash out issues with statistical analysis, you would need a statistical expert. And of course, one acknowledges their role by making them authors in a review, if that has been done. Now, what is a comprehensive literature search? You already know this by now, that if there are several sources where one could look at electronic databases, and there are several such: Medline, Embase, Web of Science. These are just some of the ones I've mentioned here, but there are many, many electronic databases. And based on which ones you're looking in, what are the keywords or phrases you're using, the language that you're using, and the duration you are choosing, it could lead to a variation in searches. The idea behind a systematic review is that you follow it methodically in order for it to be, even if it was being done in another part of the world, but if you're using the same duration, language, keywords, phrases, it should be replicable. And so finally, when you have ended up doing this, it should be documented that this is how it was done, right? So if there was any issues with the search, that can be identified by the reviewers later. Finally, fourth step is unbiased study selection. And there is, like I said, already mentioned, you don't select studies just because you like them. You have already mentioned this in your protocol as to what the inclusion and exclusion criteria would be, and you're using those to select those studies. This is based on a serially sort of graduated way of first doing a title screening, followed by abstract screening, full text screening. And if you have been able to identify and exclude those studies, there is also looking at hand searches, and hand searches are also a very important way of not missing out on studies that were not thrown up by your search methods. So reference list searching is also another way. So dual review I've mentioned there. This is the second reviewer, which is also looking at the studies on what need, independently looking at it. And then if there is a discrepancy between, whether one reviewer thought that this needs to be excluded or this needs to be included, the second reviewer thinks, differently. They discuss it amongst themselves, thrash it out, and then give us reasons for why this was excluded. Finally, you'd see something like this. This is the PRISMA flowchart for how a study selection is done. You can see that in this, there were all the records that were identified, all the records that were identified through other sources, duplicates that were removed, the records that were screened, why they were excluded would be mentioned because they were probably did not meet the inclusion exclusion criteria. Finally, that they did assess it for eligibility, and then what happens to the final numbers is what is quoted here, and what were the final numbers that were included in the quantitative analysis, right? So everywhere you have to be very clear as to why you are excluding the studies, and that has to be clearly mentioned, okay? Included studies would also find a separate table, and you could finally get to know this in the subsequent talks. Data extraction is also an important part of systematic review. You can do it directly from the study based on a pre-specified data extraction form. Sometimes you need to check with authors on lesser defined details. Critical appraisal is done next by the reviewers. Basically, what you are looking at is risk of bias, and session 1 helped us in identifying what those biases are. So what are biases? Basically, you are trying to see whether the study, the RCT that you are including, or whatever study you are including, is prone to any subjectivity by the researcher who conducted this study. There are different kinds of subjectivity here. There could be a selection bias, right? Based on whether the participants that were put into the arm that is the intervention arm, whether they differ from the arm that is the control arm in any major way. And there would be two major ways in which they could still differ, and that seek to remove those differences are randomization and allocation concealment. So you're looking at all of these: performance bias, detection bias, attrition bias. Finally, you give them these color coding. Green would mean low risk for bias, red would mean high risk for bias, right? And finally, when you have graded those, you do a data synthesis and grading. So that's quantitative synthesis through a meta-analysis. We hope to hear from Dr. Kamath on this. Forest plot, we will be hearing of in Dr. Radhika's talk, but just to let you know that this is a visual kind of, along with a visual guide to what has been done. It will have a table like this and sort of a diagram like this. So this on the left-hand side will include studies along with the author names and years. This is the intervention arm, which is talking about how many events of interest or outcomes of interest, here it would be live births, occurred out of a total of how many. And similarly, in the control arm, weight is what is allocated to the study based on sample size and other considerations. And finally, you calculate a risk ratio as to what is the chance that, let's say the intervention was high hyaluronic acid, led to a greater outcome, or the chance that it led to a higher live birth rate over controls, that is about 1.26 times. These are the confidence intervals. So this is the line of equipoise 1, right? And anything going away from it and not touching the line is meant to be significant. The diamond here is supposed to give us the final response that it tends to favor high HA or high hyaluronic acid, which means that, and it's not touching unity, the line of equipoise. So we will hear more about it in detail in a subsequent talk. Summary of finding is also what is stated in a systematic review. So while this table is basically what has been stated in Forest plot, I'm going to take you to quality of evidence grade. And here it is graded as moderate grade evidence for live birth rate, where the intervention is high hyaluronic acid in culture media versus low hyaluronic acid in culture media. And moderate grade evidence means that we are fairly certain that we are okay with the evidence that is available so far, and we can still use this as practice guideline. A high level of recommendation would mean, or a high grade of evidence would mean, that it is unlikely to change in future with future research being added to it. And a low grade of evidence would mean that even though it might be significant, here you can see it's not significant here, but a low grade of evidence would mean that we are not sure what we are stating is right. Things could change majorly in future with more evidence coming in, right? And then there are number needed to treat, which is quantifying how much you need to intervene in terms of how much effort you need to put in to get that one live birth. So 14 extra patients need to be treated with high hyaluronic acid in order. So that's something that we kind of tend to register more, NNT, right? That gives us an idea about how much importance to place on a certain intervention. So time taken in a systematic review is about 6 to 24 months. That's pretty long. And you can imagine why this is taking so much time based on this methodical way in which it is done. So need I answer more on why systematic reviews are needed? Well, it's very clear by now that if done in a methodical way and followed, if one was following all those steps, they are likely to resolve conflict on questions of interventions. They are more likely to be unbiased, because of which replicability is high. And because of all these features, they generate the highest level of evidence. They provide reliable basis for decision making, right? And this is something that some of you may or may not have seen, but it's something that all students should know. This is the evidence pyramid. And you can see from below that the lowest level of evidence, but even though it is the lowest level, it is some evidence. It is generated from animal and laboratory studies. Next come case reports, series, narrative reviews are way down there. Expert opinions, editorials, case control studies are observational, retrospective studies come next. Cohort studies, prospective come above that. Randomized control trials come above this, and nearly on top of this are meta-analysis and systematic reviews, right? So why is it a pyramid? Because you have more of those studies at the bottom, and it's in numbers also, they tend to reduce the number of systematic reviews on a subject might be fewer than the number of case control studies, cohort studies, or RCTs that exist on that subject, right? So, and based on this, you formulate treatment guidelines. So yes, there are doubts about systematic review. They may not answer all clear and not have all clear answers, because they might still say we are not sure based on what we have, because there are either no trials, or there are no trials reporting on the outcomes that one patient might be interested in, or the trials may be of poor quality. So just this last slide on what to do when systematic reviews are not really there to answer your questions. Well, you have to learn a basic literature search. You could look at evidence lower down in pyramid. So let's say there are cohort studies or RCTs, which still exist, but low numbers. You should be able to criticize them. We saw the students do that beautifully. And finally, if there is something like an error, and you were an intervention like, let's say, error in recurrent implantation failure, and the literature here is ambiguous, whether or not you apply it in your practice, you have to first understand the process, understand the mechanism of what it is trying to treat. So if it is implantation failure that you're trying to correct by doing a transfer one day early or one day late, you have to understand what implantation window is. How many people would it be narrow in, whether it can be narrowed enough by 6 hours or 2 6 hours in women who normally it is stated that it's about 3 days long, whether it can be so narrow that it would influence results. What is the percentage in which it would be narrowed to a point, and who are these women who would benefit? What are the costs of intervention? What are the theoretical benefits and harm? In any case, when we don't have a strong evidence, we don't try to push anything as miracle cure. You discuss all this with patient before offering it to her, identify the right group that might benefit. And if you are still in doubt, you could continue with established practice, right? So there is no alternative to basic reading. Knowledge of basic sciences is a must. Remember that. Subscribe, have access to 2-3 top journals, and that pretty much keeps you updated. And if you are still looking at evidence deeper down, there has to be some familiarity with literature search. I'll end my talk there. Thank you.
Yeah, Dr. Uma, it was a wonderful talk. And I think very systematically you, covered all these steps and the plus points, disadvantages, especially for our beginners and the youngsters. You've given a very beautiful insight step by step that there should be, first of all, a building of a team with like-minded people who are research oriented. Literature search should be very important. So I think all these things were very important. Many of our students keep asking us, what is the difference between systematic review and meta-analysis? So can you put some light on that?
Yeah. So systematic review is the entire process of finding an answer to a specific research question, right? So you saw the steps, which would include first identifying what knowledge gaps exist, finding the right research question, looking at building a team, writing a protocol, looking at evidence systematically, finally selecting studies, extracting data, synthesizing evidence. Now, meta-analysis is specifically that statistical step that you are doing in order to synthesize quantitative evidence. Meta-analysis is the result of that table as a forest plot that you saw, right? So, and systematic review is much larger, the entire process of finding the answer is systematic review.
Okay. So, and is there any risk? Because I think still there is a risk of some bias in systematic reviews also, depending on what kind of studies or what type of evidence you've included in it. Right. So how do you take care of that? And there could be a variable, there could be a low risk, a high risk studies, or different kinds of biases which are there in the evidence being involved. So how do you take care of that? And do you mention it specifically in the systematic review?
See, I'll leave that to the speakers of the later sessions, and they would be addressing risk of biases and other things. But largely, I think at this point, it's important to remember that, first of all, right from the first point where you are doing a systematic literature search to identify all available literature on that topic, and using an unbiased study selection method, and using 2 reviewers or 3 reviewers in order to identify those studies is the first way in doing a good, replicable, unbiased systematic review. And then the critical appraisal of studies comes later. We'll leave that to the speakers of the day. So, yeah.
All right. So one last question, that can we use systematic reviews for qualitative evidence also?
Yes, you could. I guess the methods are not very clear. And the field that we are in, we look at quantitative evidence mostly. But I think those methods need to be defined.
Yeah. Thank you so much. So Varun, do we have any other questions from the audience? Okay, so I can't see any more questions. And thank you so much, Dr. Uma. And I would request my co-chairperson, Dr. Harpreet, to introduce the next speaker. Thank you.
Yeah, thank you, Dr. Sangeeta. And thank you, Dr. Uma, for a wonderful comprehensive overview of systematic reviews. And next, moving ahead, we have important topic, identifying the research question. I feel that is the most important part of a systematic review, to identify the right research question based on which we can gather the relevant evidence, and which is going to be the important use in the clinical practice, and then how to write a protocol and where to get it registered. And for that, we have a dynamic speaker, Dr. Priya Bhave, with us to answer that. Dr. Priya is president of India Dr. Shankar Dayal Sharma Awardee for Best Outgoing Student MBBS. She is fellowship in reproductive medicine from CMC Vellore, and she's a FOGSI recognized trainer in basic and advanced infertility management. And she's first professor of reproductive medicine in whole of North India. And she has many more laurels to her credit. Before without wasting any much time, I hand over to Dr. Priya Bhave for the talk.
Thanks a lot, Dr. Harpreet, for that kind introduction. And thanks so much, Dr. Uma and Dr. Mohan, for having me for this important topic. It's really a pleasure to be a part of this very, very important workshop on research. So I'll be talking upon identifying a research question, developing a protocol, and then registering it. And as you rightly said, this is probably the most important step in the entire review. Now, a lot of what I wanted to say has been covered by Ruma, so I'll kind of skip over some slides and just bring you the salient points, and maybe with more practical examples as to how you go about writing a protocol. Now, why we know it has to be a systematic review, because we want to remove biases which are inherent to even the reviewing process. It's not that only RCTs have bias. Systematic reviews and meta-analysis can also have a lot of bias. And the best way to remove a bias is to develop a particular robust protocol and to register it a priori. Now, we all know that when we look at systematic reviews, we need a very clearly defined explicit question, a systematic search, a strategy which is replaceable. So anybody else who does the same search should come up with the same results that we had. And of course, the risk of bias, reproducible data extraction, and finally, the analysis and reporting of the results, exploration of heterogeneity, publication bias, sensitivity analysis, subgroup analysis, etc. This will all be taken up by the next speakers. But what I will be talking about is the first 3 steps, that is formulating your research question, putting together a team and registration of the title, writing a protocol, getting it approved, and finally registration of the protocol. The next 2 topics, that is search and risk of bias, will be taken up by the subsequent speakers. Now, we all know that he who fails to plan is planning to fail. And so what does planning a systematic review involve? The first important step is you cannot do it alone. In fact, Cochrane does not allow a single person to carry on a systematic review under it. So you need to have a team, and the usual composition of the team is that there is a subject expert, there is usually a methodological expert, and usually there is somebody helping on the end with the search, usually the librarian or your local Cochrane team, or somebody who is a search specialist is involved in the
team. Now, your team can be as big as you want, but usually the minimum that we have is 3. This is because whenever you are going about actually doing the review, most of the things have to be done in duplicate. That is, your searches have to be in duplicate, your data extraction has to be in duplicate, and in case there is some controversy or there's some disagreement, the third person has to step in. So it has to be a minimum of 3 people. Please remember that writing a systematic review involves a lot of time commitment, and most of us do not realize it at that time, but it does require, because the person who is doing the review is supposed to do what they do. You cannot kind of outsource it to somebody else and have somebody else write it for you. And there has to be a talent, because not everybody has an inclination towards reviewing and all that it entails. It is an extremely labor intensive process. It involves a lot of new softwares which kind of keep updating. So the time that you start a review, you were working on maybe a data extraction form. By the time you are ahead, there's some new software that comes up, there's a new update. So it requires a different kind of talent than what we have as clinicians. So first is identifying a review question and identifying whether a systematic review is needed. I remember the time where I desperately wanted to do a Cochrane review, and I was searching for a review question. What usually happens is, whatever are the important topics, they're usually taken, in the sense that these topics are already registered with Cochrane. So what you can do at this point is, if there's a topic already registered, you can write to them and you can ask that you are interested in this subject. This is the expertise that you bring in, and can you join that team? So this is probably my advice to the beginners. Don't think that you can kind of undertake a review on your own. Try joining a pre-existing team with maybe a registered protocol, or a team which is working on a protocol. And the third and most important thing is the proposed review feasible. Now, usually we should, as clinicians, all of us here are clinicians, we are not statisticians, we are not researchers primarily. So our review should always stem from our interest in the topic. Now, once you are interested in a topic, say for example, in infertility practice, it is a very common practice to give ovulatory triggers to women who are trying to conceive. Now, when you look at this practice, which is happening day in and day out, you might come up with a question whether it is really feasible, does it improve the outcomes? Now you have to narrow it down to a specific question, and then you have to arrive at the PICO. Now, whenever you do, for example, ovulatory triggers in women who are infertile, is it interesting to the patients? Is it interesting to the healthcare professional? Does it actually improve the outcome? Are there any trials which are available on this topic? Because there was a time in Cochrane where there used to be a lot of empty reviews. So person has registered a title, and then they would do the entire search, and the conclusion would be that there's no systematic review because there's only one trial. Now Cochrane does not encourage that. So you are supposed to do a review only when you have at least 2 trials which are available for a meta-analysis. So for example, this meta-analysis, ovulatory triggers in anovulatory women undergoing ovulation induction by Dr. George. So it had actually 2 trials which were included. And this is a question which is very, very pertinent to practice. Now look at how they have narrowed down the question. It's a narrow review, and they're only looking at anovulatory women who are undergoing ovulation induction and receiving ovulatory triggers. The comparator is no trigger, and the outcome is live birth rate. So whenever you come across any particular question in your practice, try to fit it in the PICO format, so much so that it becomes a habit with you. And whether then you plan RCT or a systematic review, things become easier for you.
Dr. Priya, sorry to interrupt. Can you have the slides in the slideshow mode?
Oh, I'm so sorry. I'm so sorry. I didn't realize that. Yeah. Now, sometimes what happens is that there's already a systematic review on that topic, but it has not been updated. Now, Cochrane is very open to people who are interested, who have the skills, who have some background in doing meta-analysis. So in case you find that there is a review, but it has not been updated since 3 years, you can write to Cochrane and you can be a part of a team that is updating a review. And that's the way you can be a part of such a team. Also, if new methods have been developed, suppose there's a robotic method of doing a particular surgery, you could use that as make a protocol around it. Now, please remember, I'm repeating myself, but it's very, very important that you consider the time and resources that you have. all of us are busy in our practices, and as clinicians, it's not always feasible to take out that amount of time it requires. Working on a systematic review requires at least 10 to 14 hours of commitment per week. That is, if your review has, at least 5 to 6 studies, which is a reasonably, big review. Also, if you do not have access to methodological experts, because these methods keep getting updated. As I said, the software keeps getting updated. You need to have a librarian who is going to send. Suppose you're in the process and it has taken you longer, and now you need an update on the searches. So you need somebody to run those searches and send that across to you. Most of the time, your group will help that. But in case you're doing a review out of Cochrane, for example, you will need a research librarian or an information scientist to do it. And as Ruma has already pointed out, it could be a broad review or a narrow review. A narrow review is, for example, ovulatory triggers in anovulatory women undergoing ovulation induction. A broad review is the one by Dr. Mohan, screening hysteroscopy in subfertile women, which is kind of looking at various types of women who are undergoing hysteroscopy for different reasons. Now, remember that the protocol is always peer reviewed, and it is also undergoing an editorial review. And it has to be published a priori, because there is something called as reporting bias. Sometimes you might start reporting things which you never set out to, but which you found along the way. And that in itself is a bias. And that is probably one of the biggest biases in reviews, which are probably non-Cochrane or out of those particular reporting standards. And whenever you even publish your review, you have to write the differences between the protocol and the review which you did. Now, these are the steps. So you ask a question. Now, very important is the moment that you come at a title, the title also has to be registered in a database. That is, maybe if you're doing it outside of Cochrane, you register it in Prospero, even before you have written a protocol. Now, once you ask the question, you have to ask it in the PICO format, that is patient intervention, control and outcome. Keep a meticulous record of the search strategy. Select your studies. How are you going to select the studies? Look at the risk of bias. This is the Cochrane risk of bias tool, which Ruma has already mentioned. I'll just rush through this. Data extraction, how are you going to do it? Are you going to use a software? Are you going to use forms? Who are the authors who are going to do it? And finally, data synthesis. What is the method of integration? What is the type of statistical analysis? Is it going to be a fixed effect, random effect? How are you going to explore heterogeneity? And so these are all the things, steps which are involved in writing a protocol. Now, the main pitfalls are planning, preparation, and protocol. So I will just take you briefly through our protocol of minimally invasive surgical techniques for fibroids. Our question was women with uterine fibroids, whether laparoscopic myomectomy is better or is open myomectomy better. So if you go by this method, our inclusion criteria were premenopausal women with uterine fibroids. You have to specify how you have diagnosed the fibroids. We took clinical as well as ultrasound examination. Now, whenever you compare minimally invasive techniques, it cannot only be laparoscopy or laparotomy. We've included also mini laparotomy or laparoscopy assisted mini laparotomy, and also hysteroscopic myomectomy. The primary outcome was post-operative pain within the first 7 days, and perioperative and post-operative morbidity while in hospital. Remember that there can be just 1 or 2 primary outcomes. They cannot be more than 2. The secondary outcomes, what we looked at, were the length of hospital stay, operating time, intraoperative blood loss, mortality, improvement in menstrual symptoms, change in quality of life, and recurrence. Now, the search strategy always has to be spelled out. It is quite fixed for all the Cochrane reviews, which makes it easier because you have to look into all this. Plus, you also have to look into the gray literature for publications. And also you have to look at the conference abstracts, and in Cochrane, there's absolutely no language restriction. Now, all the protocols have to be written in future tense. So review authors are going to independently scan the titles, and this always has to be done in duplicate. And then wherever there's a controversy, the third person has to step in and refer to them for any disagreement. Now, the standards for risk of bias, again, they are very, very fixed. You have to rule out with this risk of bias tool, and this has to be spelled out in your protocol. Assessment of heterogeneity, again, it has to be spelled out in the protocol. That is very, very standard. What is important, what differs in every review is what are your comparisons going to be? These are going to be your titles for your meta-analysis. So in our review, it was laparoscopic versus open, laparoscopic versus mini laparotomy, laparoscopic versus laparoscopic assisted, and similar for hysteroscopy. Now, once you have spelled it out initially, you cannot change it when you write your review. So your comparisons are now fixed. These are the meta-analysis graphs that you're going to take out. The subgroup analysis and the sensitivity analysis also has to be mentioned a priori. So what we decided is we are going to do a subgroup analysis if there's about the size of myomas, numbers, and with or without pre-treatment with GnRH analog. But we did not have number of studies or data on this, so we did not do a subgroup analysis. Now, after the protocol has been written, you have to register it. Now, registration of a protocol can be with Cochrane if you're doing it within Cochrane. There are certain health reviews which are registered with the Campbell collaboration, the Prospero, which is a database for the prospective registration of all the meta-analysis which are done outside of Cochrane and Campbell, and they maintain this database permanently. So anybody else can go and see if there's somebody already doing a meta-analysis or a systematic review on that particular topic. Now, the proforma for registration in Cochrane goes like background, method, selection criteria, quality assessment, data extraction, and synthesis. And finally, there is a section on differences between the protocol and the review. Now, once you are registered, your protocol is going to be peer reviewed. This peer review process is going to take around 6 weeks of time, and you're going to hear from them. And finally, it will go into an editorial review. Now, believe me, writing a protocol takes a good amount of time. Also, ideally, you're not supposed to do a literature search when you have written a protocol. It is a little counterintuitive, but what Cochrane suggests is that you take a review question. Don't go and start searching RCTs on that. You write your protocol, because searching of studies prior to writing a protocol can also bring in some bias. Although, of course, you cannot do it just on your own. I mean, just out of the blue, you do some research, you're aware of what is happening. Now, in conclusion, it is basically well begun is half done. And I would say in case of systematic reviews, if your protocol is written well, it is more than half done, because after that, everything is spelled out and you just have to follow it and do it as you have mentioned. In case there is a difference, then you can get in touch with your review team. They can help you, and finally you write it and the differences between the protocol and the review section. So get a good team. Remember that you have to get trained in the methods of systematic reviews, and you have to keep updating yourself because the softwares keep changing. There are new things that they keep adding. And once you have registered it, start doing your review. After you have finished your review, it's not the end. Every 3 years, your review has to be updated. So you have to revisit your review and then make modifications if there are new searches, if there are new studies which have come up. So basically, systematic review is like a live object. It keeps on changing. It's not that you've published it once and it's dead. So with this, I think if there are any questions, we could take it. And I think if there are any, they would be taken in the subsequent lectures as well. Thank you so much.
Thank you, Dr. Priya. Thank you for such a comprehensive talk. And it was really wonderful to know how to go about the systematic review, about the protocol writing. I just have a question regarding the protocol writing. At what stage, you have already mentioned about it, but for the audience, at what stage exactly we need to register a protocol, and when do we actually start with our review? Can you please highlight that?
With Cochrane, once you have registered your protocol, it goes into peer review. There will be some comments from the peer reviewer, and you might have to modify your protocol in order to answer those queries. Once it is reviewed and it is published on the website, that's when you can start your searches. So you cannot start literature search or working on your review till your protocol is published, and publication is only after a peer and editorial review.
Thank you. And how broad your protocol has to be? That is another thing.
See, protocol has to be very specific. Your review can be broad or your review can be narrow. So whenever you mention your PICO, suppose your topic is hysteroscopy in subfertile women undergoing in subfertile women. Now, what subset are you going to take? Are you going to take pre-IVF? So this will come in your patient section. In case it is a narrow review, your patient section will be narrow. In case you're talking of more than one intervention, then your I will have one or more than one intervention. So your protocol has to be as narrow or as broad as your review question.
Right, thank you. So what I can get is like we select a study question, and then after that we can register either at Cochrane or we can register at non-Cochrane sites. But after the registration and after getting the review, that is the time when we start with the research.
Absolutely.
For the review. Any more questions, Varun, from the audience?
No, ma'am, there are no questions.
Thank you.
I'll just add one comment.
Yeah, please, Dr.
Thanks,
Mohan.
Dr. Priya, for a very comprehensive one. This is a topic that I also take over here, so it's not an easy one to cover. Just to add to the current narrative about evidence synthesis. So there are a lot of issues about narrow reviews nowadays, and what the systematic reviews are slowly being very critically looked at. There is something called network meta-analysis. So essentially, what we are looking at is a systematic review. Let's say if I and you want to go and check a particular answer, you want to know, let's say, what's good for a lady with PCOS as ovulation induction. So for a systematic review now, you'll have to go to 3 or 4 systematic reviews to know how is letrozole doing, how is clomiphene doing, how is gonadotropins doing. Whereas the network meta-analysis is going to put all this together into one review. So nowadays they are also questioning why should people go to these many systematic reviews when they can just go for one network meta-analysis. So I think for letrozole and ovulation induction, there's one from Rui Wang, which was published in one of the premier journals. So the world is actually moving on towards network meta-analysis, which will combine and which will be much more broader than a clinician can just go, or any end user can just go to one network meta-analysis and find all the answers for that topic. And narrow reviews are now being discouraged in many ways, because it kind of, it is duplication of work. You can always combine 3-4 narrow reviews, as Priya pointed out, the ovulation trigger one, we could have probably included all the anovulatory women, WHO 1, 2, 3, and made it much more broader. But at that point, it was not, we didn't know all this is a part of it. It's all a learning curve. But that's the message I want to say, is the readers will have to start looking at something called network meta-analysis, which will be the future. That's all.
Thank you, Dr. Mohan, for your expert comments. And they are always very helpful. So moving ahead, I hand over the proceedings to my co-chair, Dr. Arvind Ravichandran.
Thank you, Dr. Harpreet. I think we are almost halfway through the workshop now, and hope everybody is finding it useful. We just now move on to the third topic of the session. It's indeed a great pleasure for me to introduce our next speaker, who is going to talk to us about performing a comprehensive literature search fitting the review question, what database to search, and also the data extraction process. Our speaker is currently the director and the head of reproductive medicine, Mitra Hospitals, Kottayam, Kerala. He is also a member of various national and international professional bodies concerning reproductive medicine. He is a reviewer with the Cochrane Network and has more than a dozen original publications to his credit. His primary areas of interest include IVF lab quality control, minimal stimulation ART, and PCOS. Please join me in welcoming Dr. Raju Nair. Over to you, sir, for the talk.
Thank you. Can I share my screen? First of all, I thank Mohan Kamath and Bhuma for inviting me and giving me a platform to speak on this very important topic of research methodology. Even though after my CMC Vellore days, I am a bit away from all these things, but thanks to my dear friend Mohan Kamath for keeping me pressurized for doing some research and incorporating him in this loop for doing, and at least keep me a little more updated in the era of research methodology. And the topic today is little bit exhaustive. That means a comprehensive literature search, study selection, and data extraction. I know it's a lot of things to be covered, and I will do in such a way that I'll just explain what exactly this means and take you through one of these studies which we did with the help of a software called Covidence, so that you will get a little bit practical input how exactly we do this aspect. So as Ruma has specifically pointed out, that systematic review process is actually a teamwork. And this teamwork includes many persons actually. And the basic concept which I like to highlight in this teamwork is the search of studies, selection of studies which we actually needed, and extraction of data and assess the quality. And obviously the synthesis part, I think Mohan will be covering later. So literature search is like a huge task, because with the advent of internet and other electronic database available, and you have abundance of literature in your fingertips. But how can you become a good searcher? Because systematic search requires a balance of precision and sensitivity. From this entire limited knowledge in this literature search, and our librarians will always be with your help for this difficult part of the study design. So everybody highlighted the importance of a PICO question, because we have two types of, one is the time-consuming question, that what is the best strategy to prevent smoking in young people? Because it's a huge area to be covered. But if you put this into a PICO aspect, that as mass media, like the school-based or community-based interventions, is effective in preventing smoking in a young couple. So we are actually dissecting our thought process into different aspects, like problem, young people of 25 years, intervention, mass media, comparison, and outcome. And we can add T to it, that's a type of study. So each problem has got a search criteria to it, that we can search the people, that if you put this search criteria into an Embase or a PubMed or Medscape, each of these things will be a search engine tool, so that we can get maximum hit based on this criteria. And with the good Boolean operators with add, nor, or and, or not, we can actually club these two together and get a beautiful hit, or rather the search methodology in place. We'll explain one by one. So a good search, the basic thing is a looking into, and a comprehensive search contain all domains, no language restriction, published as well as unpublished literature, and it should be up to date. And obviously we have to document the search for the replicability. Where to search? We know that the era of internet is open with a wide variety of electronic database. To name a few, Medline, Embase, Cochrane, PsycInfo, Scopus, etc. But there are other things like peer review of electronic search strategies that how you fine-tune your search. And there is something called grade literature. This site called OpenGrade will give you a grade literature of Europe. And you have clinicaltrials.gov, dissertation, thesis, and conference proceeding of different bodies. And maybe if you are dealing with an infertility scenario, there will be some good articles to be published in Nature or Science, which we may not have an easy access to. So there are different areas that we will look into. We should not define to our good interest journals. Suppose fertility, we may have fertility or RBM online, something like that. But you have to extend your search into little wider or broader perspective also, so that you can get a very good hit on your search criteria. And different bibliographic database has to be analyzed, because once you analyze, say, Embase and Medline, they use different indexing system for a study type. So if you well-versed with your different bibliographic database, then it will be difficult for you in the beginning for how to manage your searching process. So what are the components of an electronic search? What I already mentioned, describe each PICO component and start with your primary concept. So your objectives should be very clear, and find synonym. There's something called MESH, that means medical subject heading. And there are descriptors and subject heading, and obviously we have to add words. And if you want to use study filter, suppose you are doing a meta-analysis and you need only RCTs, you can put PICO-T, that means the type of studies, there is a filter you can add on, so that it will just give you the results of the RCTs only. And obviously, once you get this, you can databases, you can modify a little bit of adaptation. You can modify into different search. Suppose you put one sort of search criteria into PubMed, it may not work with Medscape. So accordingly, you have to little bit modify your search strategy. But the basic idea is start with the primary concept and just follow the Peacock component one by one. Then definitely you will be able to get more hits. And type of studies which you already covered. A little bit on what is MESH. That means medical subject heading. Because if you somebody has had search on PubMed, in the PubMed you can have something called MESH. There is a downward arrow, and we can just for the MESH type of search, because it's basically used for controlled vocabulary thesaurus used for indexing articles. So it will give you little more what do you call the broader perspective of looking for different aspect of the particular study, because you will get many vocabularies or thesaurus, so that a single word I just come across like AIDS. That means if you just put AIDS, acute immunodeficiency syndrome, or acute immuno-deficiency, acute immune deficiency syndrome, acute immune-deficiency syndrome, all these things can be of a similar word but different variants. Like synonym, plural, children or children, and spelling variant, randomize and randomize, because each thing will give you different hits. And like if you put an asterisk at the end of the stem, you will get that. If you put child with asterisk, then you will get return children, childbearing, childbirth, so on. So you can extend your search to different criteria or different extent by putting this mesh terms. And with this mesh terms, you have to put another important concept called Boolean operators. The Boolean operators is that if we just put plus symbol, that means the Boolean operators are mainly and, or not. Suppose if you want to, for an example, dogs and cat, the item containing both and cats will only come up. Suppose if you want to put Boolean operators of or a slash, dog or cat, then all items containing either dog or the cat or the both will come up. Suppose you want to eliminate cat, dogs, not cat, it's a small hyphen, then items containing but not the dog, cats. Because these Boolean operators will actually help to narrow down or widen your search. I know it's a little difficult to understand. Definitely don't worry, our librarians are expert in this matter. They will definitely help you in a better way. And study design filters I already explained, that can also be applied with the similar pattern. This is with the electronic database search. But there is another ocean of literature is called unpublished literature. Because we should know that only 25% of medical journals are in Medline, and not all published trials are identifiable by Medline. So we have at least 60% of the literature is lying beyond our common reach. So that is literally unpublished, and we may not have an easy access to. So if you're avoiding this, we are actually creating an entity called publication price, because maybe a little more information will be viable on that which we have not access to. So this can be reduced by if you have a methodology to get this unpublished literature also into the search criteria. So how can we do it? We can get this from hand searching of the key journals and conference proceeding, scanning the bibliographies and reference list of your primary study, because you identified a good study, and go to the bibliography and try to scan some of the interesting aspect which we find that is very useful for your study. And you hand search, maybe it's an old article which may not be maybe Chinese literature or some in Spanish literature. You can actually get those studies, and you can use the Google Translate to translate it. You definitely get that data in. Or you can even speak to that particular author to give the data. Definitely we can get a better understanding on that particular data of them. So definitely this will add to and increases your chance of getting more and more data to synthesize. So the take-home messages on data searching is that most important, define your topic and break the topic into individual concepts, the Peacock questions, and define words and phrases to describe the concept. That you should be very clear what you're looking into, otherwise you won't get what you're looking into. And search each concept as a separate set and combining the search set with Boolean operators, and display and evaluate the results and refine your search limit or burden depending on what you actually want. And take my word, none of us are an expert in this. Majority of time, the librarians are your friends and they will help you with getting your data. And there's something called search specialty. And if you put a review in Cochrane, once a protocol is ready, and if you put up across your research question, definitely the search specialist will send you a number of search articles for your assessment. And there you have to put your thought to select the best or what you actually needed from this lot of literature. They send it across and accordingly refine your study process and go on. And there is something called citation manager that I am not very familiar. Only one thing which I come across is Zotero, and it's actually available to some of the librarians. What they do is that this citation managers will link. This is software, so all these different citations can be linked to this, so that the accessibility of the citations will be a little more easier when we do the study at a later stage. And then coming to the second part of it, select study and extraction of data, and quality assessment and extraction of data. For this, one of the easiest thing to do is a software called Covidence. And it is not for a Cochrane. Cochrane, there's a software called Roman is there. But Covidence is useful for many other things because it is free and it helps you to work in different continents, because myself, Mohan and Mariano had a recent review published almost 2 years back. And Mariano is in UK, Mohan is in Vellore, myself in Kottayam. So we had a very good interaction, and with this software, we can have a fine teamwork, and every data is individually assessed, and we can share our data so that the further proceeding can be a little more synchronized. So why we need to analyze the data? Suppose you got an article, suppose you refined your search criteria and you got a journal article. It's published in a very high index journal. So why you want again scrutinize it? Because not all published and unpublished research is a satisfactory methodological rigor, and just because it is in journal doesn't mean that it is sound. So it is your responsibility, because your objective of question may be a little different from that particular study. Your objective of question will be entirely different, or the inclusion or exclusion criteria may be different than that particular study which is published in maybe Lancet or in EGM. So it may be, for you, it may be a substandard study. So each search hit you get, or the journal you get for analyzing, your primary thought process whether that study is focusing on your research question purposefully or not. So what reference we got, and suppose with the different search engine we get duplication. So the first thing is deduplication of the references that majority of this search engines, this Covidence will do, and then eligible studies to identify, and what we do, the initial process called abstract screen, because we just screen the abstract, and once the abstract is screened, we are eligible, then we'll go for the full test screen. So how it is actually happened in Covidence is that once we made a search strategy and we got say 50 or 20 journals or articles in our hat, we incorporate all this into our group, and 2 independent reviewers should screen all studies, starting with the title, abstract, follow-up, and full test screening. And the third reviewer should resolve any conflict. So what, at the beginning, we will not screen the entire journals altogether. First, we will just review the abstract. And this abstract, we will make into 3 different headings. That means article does not meet the inclusion criteria, should not be included in the system. That journal is totally out from that point. Suppose we are not sure or not enough information in the title or abstract, definitely you should consider it is maybe, so it is selected for a full text screening. And suppose you know from the abstract result, this is a fantastic journal that is we are looking for, definitely it comes into this. So with this abstract screening, of the 20, we remove say 5. So 15 are there. So of this 15, we are going for a full test screening. And this full test screening also include an exclude. Include if the articles meet the inclusion criteria, it should be included in the systematic review. And if on detailed review, we feel that it is not properly done, or it's not a bias is there, or it's not meet the inclusion criteria, we put it as a scrap. So this is individually we have to do, and honestly we have to do, because all voting should be blinded, meaning team members should be unable to see how others cast their votes once they do this procedure. Once they do this procedure and put it as myself or say XYZ putting the other same article on a different area, and finally we can compare whether we both the same conclusion or a different conclusion. I'll come to it in the next slide. So Covidence is an application which can easily download from the net, or is an online platform, I think. And we have 2 things, quality appraisal and data extraction. So basically, the basic process of screening can be divided into 5. One is plan. That means you have to plan with your PICO question, and you have to do a pilot study. That means suppose we are not very familiar, because in our scenario, we had actually had a pilot study, because Mohan gave us one study and myself, Mariano, and one of our other friends give assessment on this one particular study that Mohan selected. And that study, I interpreted it a different way, somebody interpreted it a different way. And with this different interpretation, a third party analyze our data and analyze and advised us, this is not the way to do, or rather this is the modality that you should follow. So actually putting a pilot study into place and analyzing how exactly the principle of the investigator want to do, then we can have a little more better understanding rather than doing all these things and creating a mess and later on doing your again and again. So once the pilot study is over and you are comfortable or your team members are comfortable, this is where I'm going to analyze this data. Then you put all the studies into place and start doing the quality review and extract the data what you want. So the major thing what we are mainly looking at is something called bias. That everybody knows that bias is an important aspect in any study. And there are different biases. I'm not going to the details of it. But based on this biasing, Covidence has got 7 quality assessment templates. This one is called sequence generation, allocation concealment, blinding of the participant and person, blinding of the outcome assessment, incomplete outcome data, selective reporting, and other sources of bias. Basically, they are analyzing these different bias quality assessment tool in a different terminologies maybe. So I just demonstrate how actually we did. So there is actually use of supernatal embryo culture medium to improve the pregnancy. That was the study design. And we included almost 9 articles. And 10 studies were imported for screening. None of the duplicates were removed. And 10 studies were screened. 0 studies were irrelevant. And 9 full text studies will assess for eligibility. And 9 studies were included. So this is how you get the frame of the Covidence website, what you get. So here, what you see is that you have selected article number 4, article number 5, article number 6, and you have something called quality assessment. And the quality assessment as well as the data extraction. So these 2 parts is there. Suppose you had to do as a first reviewer, myself, second reviewer is my friend, and the third consensus is done by a third party. So as a first reviewer, I click on this quality assessment. Then I get this article in my site, and I have different sequence generation, allocation, concealment, blinding, and based on that, how I vote for it. Like that, we are basically assessing the quality of this particular article based on our question of our systematic analysis. So basically, I analyze, say, sequence generation. And in this particular paper, actually, I don't know whether the sequencing they made is a standard methodology or not. So what I say I am either unclear or I could say high. Suppose it has got a very clear opaque sealed envelope like that, what we do in our RCTs. If you have very specific answers that you can say risk of bias is low. But if you are not sure, or maybe because of your ignorance, you are not sure that it is good or bad, you can put it either unclear or high. Like that, for different assessment, quality of assessment, allocation, concealment, unclear, blinding the participant is high, blinding of outcome is unclear, incomplete data outcome is low. Like that, for each variations, you are putting your thoughts into. And finally, you put this data further into. And meanwhile, your second observer will also do the same study, and we can have a comparison. And I said high because I don't know whether this is a standard methodology. Mariano said it's unclear because patients were randomized into 3 groups using color marble lots drawn by technique blinded to the patient and information. So we are actually not familiar with this. So when these 2 uncertainties come into play, the third party chips in and the third party analyze this data and say whether it's a good or bad. So we'll take into a consensus. Like that, each individual give an honest opinion on how they do this analysis or rather assessment of bias and coming further. This is how the quality assessment is being done in a Covidence paper. I think this more or less the same thing because there are sometimes we'll get more or less equal because both people say it's of low bias. So we can easily take that that part is set it. So we don't have to look for any other third party consensus in that. And once that is done, we go for a data extraction. Data extraction is little more tedious job because here we need to be clear what information we actually try to get from the study. You have to get the study details, you have to data for your analysis because you have a very clear understanding what exact question you are going to answer. And you have to get information related to methodology, population, intervention, and outcome. Your pick up. And here also, Covidence give you a beautiful, easy access platform that on your left side, you will get entire data, entire full study material with you. And here you'll get a summary. You can put your identification of the authors, all sort of thing, methodology, what type of design it was done, the population study, the interventions done, the outcome done. But the problem is that how much data you are going to extract, because what effect of measure you are going to calculate and what data you need to do this. It's actually a difficult, a tricky question. And before itself, you should have a clear understanding of how to analyze this analysis, either by intervention or by study design. So like that, we have to little bit fine tune our data extraction process. And more importantly, the roadmap is remember your protocol, remember your initial PICO question, accordingly you have to follow. And second, how much to extract. It is very easy to just cut, copy and paste it there, because you will actually, you're destroying the whole aspect of it. For example, one study, we have an inclusion criteria and exclusion criteria. And we know that this inclusion criteria is elaborately written and we don't want to spend time on it. We just say, just cut, copy the entire inclusion criteria and paste it in the page. And it's actually, we are losing a commendable time in analyzing. But if you do a little bit of homework and whether this inclusion criteria is stick to the protocol which we are destined to look into, we can very well come to a conclusion that this is not proper, it can be rejected or it can need some more revision. And basically your thought process or your thoughts can be type written so that the other person can have a look and get a common consensus accordingly. So extraction of data, construct easy to use forms and collect sufficient and unambiguous data that faithfully represent the source in structured and organized manner. For this, Covidence will definitely help. And this is how the methods has been assessed. Like whether it's RCT, case control study, you just need to click, that's all. And the population, what's the inclusion criteria. Here, your purpose is not just to cut, copy and paste it. Your put is whether that inclusion criteria fulfill your data and exclusion criteria, the group difference. This information you have to practically write on it. And the intervention, what's the description of interventions? And the outcome, what was the outcome? So like this, from that particular study, you are extracting the data, what you want for your subsequent analysis. And that is called data synthesis. So like that, once that particular thing is done, we know that we imported the analysis, the risk of bias assessment has started, and notes were added by another person and undo added by another person. So as a teamwork, we are able to find a final conclusion and the full text review can be done. And which software? I just told you about the software called Covidence, but there are different software called Revman, EpiReviewer, and even Word or some paperwork you can do for this purpose. But an automated or a software-based thing is a little more easy and little more, what do you call it, time. You can save a lot of time and you can deal with the different people and everybody chips into that same platform. So it will be easier with this Covidence. And basically what you are familiar with, what package best suits for data, and how many are included studies do you have. So depending on that, you can choose the software of your choice. And once this data is accurate, you go for a data synthesis. Here also something what we call the Prisma flowchart. Here also we can enter in this shinyapps.io. We can have this included studies, but all studies are included, why is rejected. I think Mohan will be taking from further onwards. So this is in nutshell about how you search, how you assess the quality, and how you extract. To conclude, a comprehensive search is needed, and that is not a joke, and a librarian's help is very much needed for this, and need training in literature search. Actually, if you go to PubMed and or rather YouTube and you ask for how to do a literature search, actually there are very good videos on how to do literature search. I mean, this literature search in Medscapes and PubMed. Initially, we find it still difficult, but with experience, we may be able to get a little bit of data out of it. And input from the search specialist is obviously advised, especially in Cochrane and all, you get a specific search specialist, they will do the job for us. And study selection needs clarity in eligibility. And this is where you have to put a little bit thoughts on, because this is the main homework what you do, because you have to select the ideal studies. Then the other data extraction, even though it's time consuming, we can get it done. But if the study selection, which is mainly the work as a clinician you are doing, you have to put a little bit honest to that thing. Then the things will be much easier. And obviously, it's a neat combined effort of the team. So finally, the nutshell about any systemic data analysis is that it's a teamwork. You cannot do independently. You are not a champion of all this, because it has to be mutually respected and take the thoughts from different people. Different brains will be working for a common subject, and obviously we'll get a finer data extraction and a better outcome from the study. I think, thank you from my part.
Thank you, sir, for that impressive talk. I cannot agree enough with you on the fact that performing a literature review for a systematic review is quite different from a literature review for an original article. It kind of does include the grey literature you were talking about in terms of the dissertations, the conference papers, maybe government research, maybe clinical trial data, which is yet to be published. I think it kind of touches upon those essential grey literature also, which might not be contributing to the final outcome per se, but at least they have been considered before a final outcome has been presented. We have two questions, I think, in the chat box from Dr. Ruma. I'll just try to convey them to you. Are there any resources for conference papers outside Medline? That is one question. And also, while performing a quality assessment of studies, when they are being used for systematic reviews, who's the third party involved in it, in doing the quality check? It's something which Dr. Ruma has posed. If you can throw some light on it.
The first question, definitely, I don't have any specific answer, because it's a strategy mainly given by the library, and especially when it's associated with Mohan, maybe the Cochrane or the other people will give the data. But definitely, there's something called, if you look into for this presentation purpose, I had a search on this aspect. And there are some websites which give you an access to this part. And mainly what they do is that the studies which you are intended to get, you basically contact the particular researcher and try to get the data, or ask him whether we can get the data of that institute. Like that, a library to library search will give you an expert opinion on getting this sort of data. And second, incorporating the third party for assessing is a good thing, isn't it? Because a different brain is working on a common aspect. So the more the brain pushes the data, definitely you will get a little more finer fine-tuning of your answer.
My question,
yeah.
I'm sorry if I'm allowed to just.
Yeah, please.
An author, the third party is an author, or is it, can you hear me? Is it an author of the review, the third party?
Need not be.
All
right. I'll just step in. I think Raju, I think what she's trying to say, in a team, usually two people will do it, and there's a third person who will agree or disagree. So he's a referee. This happens for all the stages, probably the search when you have to decide on the final studies, risk of bias, or any data extraction issues. So there is, we always write, we will consult or go to a third author. So if you see any systematic review, there'll be an initial for that person. So usually any senior person will be the one who will be the third person. Yeah.
I think the other question from Dr. Harpreet also touches upon the same aspect as to how to do the quality check for the studies. I think it's pretty much answered. So I think I'll hand over the session now to Dr. Ruma to carry on to the session 3, which will be focusing on the forest plots and the biases.
I just want to add one point here, just for sake of completion. So one of the things that Raju said, it's very something that all of us are not probably cognizant of, is there's a huge publication bias. It happens at two levels. One is that published literature, most of it, the editors end up accepting the positive studies. And that is why what you and me read up every day on the journals will be most of them would be positive. Whereas the negative studies, after 2 or 3 failed attempts from the authors, they will give up. So they will never reach the surface. And I think there's one paper which was quoted in 2008 where FDA registered trials out of, let's say 100, 95% of the positive studies got published, whereas hardly 14 or 15% of the negative studies got published. So that's what is happening at the background. So all of us, when we read up, we need to be cognizant that only the positive studies are getting pushed up, whereas the negative studies don't get pushed up. So 2 reasons. So that's where, so even a comprehensive search will not probably yield those negative studies because they never were published. And the second source of negative studies is the CSR report from pharma companies, which is like the trials and studies which have been done, and many of them are not shared because of various adverse outcomes, and also it will never be in the public domain, and there are no real ways of getting those things. So be very sure that a lot of negative data is not there in our systematic review. The only positive things come up. So this is on the background of all the systematic reviews that we have to be aware of. Publication bias. Thank you.
Thank you, Dr. Kamath, and the speakers of the previous session. I hope the delegates have been listening in very carefully, because if you thought the previous session was technical, this is likely to be even more so. And for this, I'd like to invite our chairpersons, Dr. Surveen Guman, who is the Director in Fertility and IVF from Max Group of Hospitals, New Delhi. Varun, please could we have the CVs? Thank you. That's Dr. Surveen. Thank you, ma'am, for joining us. And Dr. Shikha Jain, who's the Director and Chief Consultant at Dreams IVF, New Delhi. Thank you, Shikha, for joining us. I believe Dr. Prerana is not with us yet, but as and when she joins, we can have her over. But Dr. Surveen and Dr. Shikha, please take over the proceedings.
So we are, good afternoon. And at the outset, thank you, Mohan and Ruma, for involving me in this very important workshop. So this is the last session of the workshop, and I think a very important session. Our first speaker is Dr. Mohan Kamath. We all know him for all the work he's done on this aspect. He's the Professor of Reproductive Medicine, CMC Vellore, on the editorial board for Cochrane Fertility and Gynecology, Associate Editor, Human Reproduction, on the editorial board of Fertility, Sterility. Many more accolades to him, more than 75 publications, and a peer reviewer of a number of journals like Human Reproduction. So over to Mohan on one of the most important topics of bias, risk of bias, and how do you assess it? Because whatever is published, if it is biased, it is no longer true.
Yeah, sorry. Yeah, thank you, ma'am. That was a very kind introduction, and I'd like to just straight head on to the topic, because I think it's a very large topic, as most of our previous speakers have had to cover very large topics. Normally we cover these over a couple of hours, but I'll just try to touch upon certain aspects of risk of bias, because this is an important part. So let me just go on with this topic. So first, we need to ask ourselves, why do we need to do this? And then I'll just probably take you through the steps of doing it. Okay. Now, just to give you a snapshot of what's happening, all of us know now that there's so much of data and trials coming out for the COVID vaccine. So everybody is now getting a fast forward lessons on evidence synthesis and what all can go right and wrong in these. I think everybody is now knowing how phase 1, 2, 3 trials also are coming up. I think COVID has taught us many lessons. That's what I would say. Now, overall, the thing that we need to understand is how reliable are the trial results. Okay, that's what we are trying to do. So as a clinician, you need to probably dig in a little deeper. So I'll just touch upon certain very complicated words, validity, and so on. We are not very used to it in scientific terms. So what it boils down to, can we trust the evidence? Okay, so is the internal validity there? That means that can we really say that the study has been free of bias at all the levels? That is, designing a nice trial is a good thing, but executing it is another thing, and reporting it is another thing. Okay, so please remember that you might have a fantastic protocol, but you might not be able to execute it for various reasons. And the worst is that reporting it in a skewed manner can probably create more bias. External validity is something different. It's about application of the trial results to other populations. So I'm not touching on that. Systematic error. This is a very common term used. To simplify it, if there is a bias, it essentially takes the results in one direction. Okay, it goes either it takes the study results to harm or benefit. It just pulls the results. Let's say there was 1% benefit, it will push it towards 10%, or vice versa. So remember that if there is a system, a random error is chance, it can happen all the time because we are not randomized the whole world. But then systematic error is we have done some mistake at design or execution stage that it will pull the whole results towards one side. And this is something that we need to identify. Now, why should we do that? Because poor quality trials, especially in a context of systematic review, can create a lot of problem for us. I think Dr. Radhika ma'am is going to take up the meta-analysis part, the forest plot. But remember that all types of trial are going to make it published and unpublished. And what it is going to do is it's going to exaggerate the treatment effect or the benefit, what we call it. It's all very sophisticated statistical words, but overall what it is saying is if the benefit was 5%, it will start looking like 25% in the final results. And that's what we should be wary of. The truth could be very different from what actually it is being shown as. So this is how the forest plots appear. So if I just give you a hypothetical situation where you have a very poor quality trial 1, which is showing fantastic benefit for this particular intervention. Whereas a trial 2, which is actually a larger trial, is on the other side. It is not showing any benefit for the intervention. So when we combine this in a forest plot, because the effect, that is the benefit, is so large in this trial 1, that you can see that the whole results have been skewed. And what we will do, we are all busy clinicians, so we have to just go look at the abstract and we figure out, oh, risk ratio is 1.3 and it's significant. We won't really look at the quality of evidence, risk of bias, and all that we want is cherry picking we end up doing. And we kind of say this is significant, let's try this on our patients because they probably need our help. But it's not as simple. And that is where the risk of bias comes in. How do we address this issue of poor and high quality trials coming in? How do the authors of these systematic reviews balance it out and present a balanced view in the conclusion? Because that's what we are looking at. So as I said, bias can occur at any stage. So I don't want to run through all this, but remember that only 2 people have to do this. And this is where the rapid review differs. Rapid review only 1 person will do because we are in a kind of a hurry to get the results out. For COVID and all, it's rapid reviews. But conventionally, 2 people, as Raju was kind of trying to pull this out, 2 people will be doing it, and any disagreement about any decision has to be done by 3rd person comes in. Biases can come in all these domains. So at least 6 to 7 domains are there. So now, if you remember our first session, which was touching upon selection bias, performance, attrition, detection, reporting bias, and there are other biases. So you can actually see this and all. End result of all this exercise will be, you'll have this green and yellow and red. Okay, this is called the ROB tool. It is presented in table, graph, or figure. So I'm just going through probably an example of one of the trials that I'm a little more familiar with. Let's say we all have this penchant of giving antioxidant to men, especially even if they are undergoing ICSI, we feel somehow the ICSI results are going to be better. So that's the hypothesis. Is antioxidant therapy better than placebo in men undergoing ICSI, let's say ICSI for male factor, and the outcome is live birth. So that's your PICO statement there. Forget the COVID example, I'll just move on. So these are the 6 domains that I'm looking at. Okay. So I'll just touch upon each one of them by example. So let's say the selection bias. Selection bias is all about randomization. When we select the population, are we introducing some bias in the way we go about it? So that's sorted out if you are going by randomization and allocation concealment. So if now the problem is people just mention these words, but without really understanding the true implication of all this. So the essential part here is the message that has to go across is when you are randomizing, you're essentially trying to make both the groups comparable. Okay. Because we don't have the luxury of randomizing twins, identical twins on 2 arms. That luxury we will never have in medical practice. What we'll have is a general population where we are trying to randomize. So baseline characteristics have to be comparable. Now I'll touch upon this again. So performance bias is something that we were talking about the other time, in the first session. Participants and clinicians, if they are aware of the allotment. So let's say the antioxidant trial, one of the comments was that The other arm, actually, we did not give any antioxidant. So that was like, they were aware that they were not getting they were not blinded. Even the clinicians obviously were not blinded. Outcome assessors were also not blinded. So that can introduce a change of behavior in either in the participants or the clinician. Okay, so this is again, I'll touch upon when I come across for individual domains. Attrition bias is about how many participants were lost for follow-up. Okay, they didn't stick to the protocol, or they just disappeared from the trial. So that is something that if you have a lot of dropouts, like if I remember the ERA study, the dropout, in fact, they had 50% patients who refused participation. That was much before selection bias. But the point I'm trying to make is especially relevant in cancer trials and so on, where if intervention is very toxic, you'll have a lot of patients who will drop out of the intervention. Even though the intervention is effective, they will drop out, and that can skew the whole baseline variables, because you'll be left with very few patients, and it might be that we might not be able to get a valid result. Detection bias in our context of IVF and infertility, where you have live birth as an outcome, it is not a big issue even if the blinding is not done. However, if you are in a field of psychiatry and you are looking at depression and symptoms which are very subjective, there blinding makes a lot of difference. Okay, so because if people are aware of who has got what, they are likely to get biased. Reporting bias is all about how much we change our outcomes halfway through or after the trial is completed. So let me just touch upon each one of them just to give an idea. Hopefully in next 15 minutes, I'll be able to touch all of them. So random generation sequence. So this is the first domain, selection bias, single most important domain. And this is critically looked at by all the authors of systematic review. This is essentially to ensure that there is no systematic difference at the baseline level itself. Okay, that's what it means. And you have all these methods. I'm not going to go on this, but I'll just share one example. Like once for a Cochrane review, we wrote to an author. They had just simply mentioned the trial was randomized trial, and we randomly distributed the participants into 2 arms. So we asked them exactly what was the way they had randomized, and they said we randomized according to weekdays of the OPD. So Monday means group 1, Tuesday means group 2, and so on. And that is not a true randomization. That is called quasi-randomized trial. So it will get eliminated because it's got a risk of bias. So remember that there are studies which have looked at this critically, and it are all published in NEJM and JAMA, where if you have non-randomized trials, they tend to overestimate the effect. Very complicated statement, but essentially what it's trying to tell you is that if you have a trial which is non-randomized for, let's say, antioxidant, it is going to overestimate or exaggerate the treatment benefit. So if there was 5% benefit, it will start looking like 15-20%, and everybody will get very excited about it. But that's not the truth, if I may call it. So I'm just showing you a snapshot of RevMan, and this is how we actually see if these authors have not really demarcated how the randomization was done, and they don't give clear answers to the email, then we categorize them as unclear. Whereas this particular study actually mentioned how they had done it, computer generated. So we have categorized this as low risk. Moving on to allocation concealment. This is often confused, and most of the trials do not have this detail, and they get in trouble because of this, that how exactly after you have generated the randomization sequence, you're going to allot the participants. So this is where, again, there are some agreed methods, and there are some which we don't like to use. So world has actually moved on to central web-based allocation. We are still busy with our sequentially numbered identical drug containers, but then world has moved on to web randomization. So it essentially combines randomization and allocation concealment. And this will ensure that the person who is randomizing doesn't know what's coming as the next one. If you open up this envelope, whatever the group is, you'll have to allot the patient or the participant to that group. You can't really manipulate that bit. Remember that allocation concealment is different from blinding. Blinding is after the process of randomization is done. These are two very different things. You'll have to probably dwell deeper just to remind. But as I said, this is again the same thing. Every step of these domains, if you have introduced a bias, it is likely to overestimate the effect or true benefit. So this is an example I have given where I don't want you to go through the text, but overall we have put it low risk. I'll just show you why something was high risk. So this was categorized as high risk. Why? Each of the investigator opened the randomization code, and then we asked them a specific question, and they said, yes, the investigator knew beforehand that what was the randomization sequence. So they have actually exposed the whole randomization sequence, and allocation concealment is gone. So it was adjudged at high risk. So performance bias. This is what I was trying to probably hint out in the previous session, that blinding is sometimes possible and sometimes not. So in the trial that was using corticosteroids, you could have blinded with a placebo saline similar looking. Now surgical trials have a problem, and typically surgical trials will not have blinding. We can understand for ethical reasons. Now, one of the comments I thought I'll share here was one of our trials, antioxidant, which was not blinded. So what can happen is, if you don't blind in this kind of antioxidant therapy, the ones who are in control arm can easily go to the counter. Over the counter drugs are available. People can get vitamin C, E, and so on. So how do we figure out that the control guys did not take antioxidant? So if it was blinded and you had identical drugs, they would have probably been done better. You wouldn't have performance bias. And this was taken as a limitation of our trial. So these are all very important steps. So I can show you here how it is being judged. So for a particular intervention, this was about embryo transfers, DET versus single embryo transfers. And we felt that there will be a performance bias if somebody knows how many embryos are being put, be it at the embryology stage or the clinician stage. Not the participant per se, but probably the clinicians might get biased, and we had to put it as open label high risk. Whereas here it is a double-blinded study and it was categorized as low risk. Similarly, as I said, detection bias is more about whether the outcome is objective or subjective. So in this field, it's more about objective. Live births are objective. There are no two thoughts about it. So our assessment usually is low risk, irrespective of blinding. Okay. So I can show that as an example here, that we have put it. This is, even though the performance bias is high risk, I have categorized this trial as a low risk for detection bias. That means because we have given an explanation here that the nature of outcomes was objective. So we categorized all the trials in that review were under low risk because of objective outcomes. This is the same. It's about low risk. This is a big problem in cancer trials. Attrition bias, we call it. It is possible that even our trials will have this, but just to give an example, let's say that you have a cancer trial going on and a drug A, which is a new drug, is very effective. We know that a lot of patients will improve. But then the fact of the matter is that it is very toxic drug. And halfway down the lane, most of the patients, or let's say 70% or 50% of the patients, end up dropping out of the trial. So remaining, let's say you have only 30% of the patients remaining, whereas in the control group, you have almost 80% follow-up. Then it's likely that the true effect of this particular drug, that is the true benefit, might be missed. Okay, and that's what the dropout is going to create. So this is called attrition bias. And if somebody says no missing data, I'll put the scanner on that particular trial. And typically I catch up a lot of trials when they say 200 randomized and 200 were followed up. That is not possible unless we are in another planet. So that's something that we need to understand. And if people don't give reasons, missing data is fine, but you have to give reasons for that. So remember that one of the ways of reducing this is bias is by going for something called intention to treat analysis, which was mentioned in the first session. So that's about, if you look at this particular, this is a TB review on anti-tuberculosis, and you can see that one of the regimens, INH regimens here, had 53% dropout compared to 18% dropout, and we had to categorize this as high risk. Okay, so if you see, these are all issues about poor execution of the trial. Okay, people might have very grand ideas at planning, but when we execute it on ground, randomized trials are very difficult to complete and all, because you'll have so many problems that come up. Reporting bias, this is something that is easier to pick up. What it essentially means is that there are some, let's say we started with a study which showed which had an outcome of live birth rate. So I am very fascinated with one of the drugs, let's say GCSF or PRP, that's a new kid on the block. And I have this intuitive thing, or I have a liking for that drug. So essentially I launch a trial with live birth rate as the main outcome. And when we figure out that when the trial is over, that the live birth rates are actually not significantly different. But then I'm not, I still want to tell the world that no, there is some benefit of this drug. And let's say that the positive pregnancy rates were significantly better, but eventually because of miscarriages and so on, live birth rate was not significantly different. And then what I do, I just take off the live birth rate from the manuscript. So when I submit it for peer review, I will just keep all the outcomes except the live birth rate, and try to convey that the PRP or any of these new drugs is actually beneficial. So that is called reporting bias. It is common than we think it is. And the way to follow this one up is just go to the trial registry and figure out what these authors have committed in upfront before the trial. What are the outcomes they have committed? And if you find out that they have not committed for an outcome, but they have reported that in the manuscript and they have not mentioned the reason for such a change in stance, then it is under high risk of reporting bias. Okay, so remember, there is some detective job for many of us reviewers, and we do it quite well nowadays. So there are ways of finding the selective reporting, and when we have doubts, we just put it under unclear, but that is something that I can touch upon. So if you look at this selective reporting, this trial was prospectively registered and all the pre-stated outcomes were reported. So low risk of bias. And this one was, there was no registration and no efficacy of the drug reported. So we were worried about this and we kind of put it unclear. We could have put it under high risk as well. Final domain is about other source of bias. This is, as I mentioned, baseline variables can be skewed, and that can create a problem in smaller trials. Study design, worst of all, is premature stopping of trials. Many times we end up stopping the trials, and that can be a source of information. Let's say a pharma drug is being investigated and halfway through they figure out that this trial is not going anywhere and they stop it. Okay, they find that the drug that they were trying to check hasn't been successful and they stop it. That can introduce some amount of bias. And there are other issues as well, conflict of interest and so on. So all this is basketed under other source of bias. Typically, when you judge all these things, this kind of graph, red is high risk of bias, yellow is unclear, and green is low risk. I mentioned this the other time as my passing comments, that among 74 FDA registered studies, 31%. So you can make out the last line was actually only 51%. Actually, most of the trials, 94% trials were published were positive, whereas very few of the negative studies. So this is out of trial bias. It is called the publication bias, and it's a huge thing. As editors, I can tell you that this is a big problem that our end users, that is you and me as clinician and our patients, will never figure out. There are a lot of data which was showing no benefit, and there are not much to do about. Now, the problem is you've identified certain trials are of poor quality and certain trials are high quality, but how do you put them together? So Dr. Radhika ma'am is going to put that one that you are going to put them together, but how do you figure out and take off the influence of the poor quality trial. So one of the ways is take them out of the primary analysis. You only put the data from the high quality trials. And second is you do a sensitivity analysis and see whether the study results, that is the final conclusions, change if you remove or keep these trials. So this is one of the ways. See, as I said, allocation concealment is very poorly reported. So those trials we did report allocation concealment, we had one result, but the results are fairly okay with the other one as well. So there's not much change as I see it from here. So I am more confident about my results. This was a problem we had in screening hysteroscopy, where two of the trials, actually only two you can make out, the INSIGHT trial and the Altuki trial was all green, rest all were yellow and red and all. So the pooled results showed some benefit, but high quality did not show any benefit. So that's the problem that reviewers will face at the end of finishing the systematic review. So we actually guarded it. We gave a very guarded conclusion, and I hope the authors, the end users, all the patients and clinicians read this, that low quality evidence did show some improvement in results following screening hysteroscopy, but the pooled results did not show the benefit. And importantly, the Cochrane has taken a decision to no longer commit on the pooled results from all trials. They will only commit on the high quality trial in the abstract. So next time onwards, you will not see the first two lines. So I'm just coming to an end. This is a summary, the grade. If you ask me, where is this finally affecting the grade evidence? So if you look at this, this is all very low quality evidence. But if you look at the footnote here, we have downgraded the evidence because the risk of bias was there. If you look at this particular A line, downgraded by 2 levels because there was a risk of bias. And that is how the grade of evidence, that is moderate, low, or very low quality, will change because of the risk of bias. All of us are busy trying to learn ROB1, but the world is already moved to something called ROB2. So we have some catch up to do. Take home message, experience with randomized trials, critiquing them is a good start for ROB. There is still some degree of subjectiveness. Risk of bias is linked to quality of studies. And there is a problem in meta-analysis when we actually pool these low and high quality studies. That is why, as I said, we are moving towards presenting only the high quality data, even after the whole systematic review is done. Thank you. Yeah.
Thank you, Mohan. I think that was an excellent talk on one of the most important topics. So we do have one question in the chat box. It's from Ruma. If a study has a high risk of bias on most of the indicators, is it necessary to include it in evidence synthesis, or can it be dropped?
Yeah, so one of the things that most of the Cochrane people say is, we should not get biased at the earliest stage itself, that we start deleting studies because we feel they are under some bias. See, remember, these are all under suspect category, and we are not very sure that actually things are, done or the results are not so. So they are, the way the forward is that, as I said, primary analysis nowadays, we have to state upfront that only the trials from which are low risk of bias will be presented, whereas sensitivity analysis will pull in all the trials. Okay, so now no longer the Cochrane, when it comes off in the next year onwards, you will not find in the abstract the results from studies which are biased. You will only find trials with high risk, which are low risk, and the results from them. However, in case there are no trials with low risk of bias, then the authors will have to probably just state whatever is there. That's way, but we can't totally eliminate it. It will be there in the review, and reviews run up to 80 pages. So probably we'll have to just screen through that. Yeah.
Okay, I have a query. You are a reviewer of some very good journals.
Yeah.
Now, as far as bias is concerned, when you're reviewing an article, what forms your rejection as far as the bias is concerned? Where do you say, okay, now I'm rejecting? Is there something which you have in mind when you're reviewing these?
So ma'am, the main thing, like morning only I rejected one of them, Now, what actually happens is nowadays we take it very seriously if methodological issues are there. So if I am convinced that there is some methodological issues, like I find that there is no registration, or people have just kind of given very vague methodology, we might sometimes in certain situations give one chance for clarification. But if we don't find any, if we are convinced that this is, two people actually discuss this between us editors, and if we convince that there is methodological issues, it is now taken very seriously. So that's one aspect. Of course, there are other aspects about how the sample size is. If first is methodology is all fine, but topic is of interest and originality is there and everything has been done. Of course, those other things like how well it is written. But to me right now, world over, methodology, if it's apart from originality of it, methodology is being looked at very seriously, because that has created a lot of problem in terms of evidence synthesis. Yeah.
So what about reporting and all? Do you take that seriously? Would you reject on that basis, or would you kind of let it go?
What reporting, ma'am? I didn't get that.
Reporting bias.
That is the outcomes. If people have started putting in, like they'll have to justify it. If they have added a new outcome halfway through, or like after the study, or they have done some post hoc analysis, they should be really able to convince us. And we'll be looking at where it is coming from. It's a company sponsored trial and all those things. So overall picture will be looked in. But if people add and try to, and that new added outcome is showing very different results from what was agreed upon, then it doesn't sound good. So those are the things. It's a total consideration. Yeah.
Just one thought, like there's so many biases. I actually feel that every article should have this graph right in front, the red and the green. When we look at an article, we should also be able to look at how the bias has been graded on this article.
Yeah, so ma'am, that the systematic review will have that individually in front of each trial. It will be there. Only thing we'll have to, that's why probably we call it ready reckoner. The systematic reviews are like the clinician should first go to the systematic review and see what kind of trials were there and quality, and then go back to the primary trial. That would be one of them.
What about the individual articles? Why don't we grade them in a similar manner and put them there?
No, we do that. We do the risk of bias for individual trials. So we will have that red, green, and yellow in front of each trial.
To us when we read it.
It's there in the systematic review.
It's not there on the journal.
An
individual article being assessed for bias, like this particular table should just be there right by the side of the article, so that whoever is looking at it and putting it in their talks knows exactly what it is about.
Probably
that's a thought on my side.
Yeah. I think it's an interesting discussion. Very good afternoon to all. Can I also add a comment to that? I think Surveen, by coloring the article so much, in fact, we want people to read through the article. None of the RCTs, like Mohan just now said, you can't have 100% to start with and finishing off with the same end. So everywhere, any study that you take will always have a lot of red colors and orange color.
But that should be displayed is what I mean.
Fine,
but just the thought that yes, there is a bias here. Have a look at it before you talk about it.
But the moment the reader reads it, the mind gets colored. Then you don't take it so seriously. Then you think the quality of the article is not so good.
They will not stop. Then the journal will be in soup, no? Because
exactly. It is a journal. It is the journal.
But that would actually finally end up improving the quality.
No, not necessarily.
Everybody will take care. Nobody wants students.
In fact, journal impact factor is also affected by poorly published articles. That also elicits a lot of response. So the journal impact factor is known to improve with poor articles also. But then finally the reputation suffers. So the journals don't want to make it so transparent also.
Dr. Mohan, your talk was very nice about the bias and all. And I had just one thought to clear that there are so many retrospective studies. I think we are more biased in respect of this in comparison to the RCTs and the prospective studies. We see a lot of retrospective studies published, and so they are more prone to have biases.
They have all the non-randomized studies will have huge biases. They tend to overestimate the final effect much more than an RCT, and especially so in retrospective, because in retrospective, see, suddenly I decide to go back and start looking at my PCOS woman as a thing. You know how many changes have come over the last 5-10 years in terms of diagnosing. Who has diagnosed it? It all varies. So there can be so many confounders in a retrospective, but they have their place. I won't say that, but it is probably a starting point. You always look back at your retrospective data and then try to hypothesize and move forward in an RCT. Yep.
Right.
Over to you, Shikha.
Okay. So can we proceed to the next talk by Dr. Radhika ma'am? Dr. Radhika is a senior consultant at UCMS and GTB Hospital, Delhi, and she's a national corresponding editor of Journal of Obstetrics and Gynecology of India. She's a national coordinator for clinical research, FOXY. She's a member of so many journals and expert reviewer for NIHR UK. And her topic is forest plot. Radhika ma'am, you can start.
Thank you, Shikha, for the introductions, and thank you, Ruma and Mohan, for having me here. So I've been listening to you off and on, and I think it's a very well organized, interesting workshop. So considering today's workshop is basically for the postgraduates, I've tried to keep my talk very basic. So the talk is on the forest plot. So the learning objectives would be what is a forest plot, how to interpret it, and how to draw one. So since afternoon, I think a lot has been said about the systematic review. It's a comprehensive summary of all the available evidence that meets a predefined eligibility criteria to address a specific clinical question. And by and large, systematic reviews could be of two types. They could be narrative or along with meta-analysis. And systematic review and meta-analysis happens to be a part of systematic review, and they are not interchangeable. And as I said, not all systematic reviews could be having a meta-analysis. And the systematic review is based on a very rigorous process of identification of studies, critical appraisal of the same, meta-analysis, presentation of findings, and explicit discussion on the limitation of the evidence in the review. So what exactly is meta-analysis? It combines mathematically and summarizes the results for a specific outcome as extracted from several studies. And these several studies have been critically appraised. And that is why meta-analysis is viewed with some respect. And since afternoon, there have been a lot of discussions regarding the extraction of these studies as well as the critical appraisal of the same. Now, when there are these useful studies, they could as well show two kinds of results. There could be a mixed bag of positive and negative findings. And the meta-analysis is expected to provide an objective average. And another advantage is when you have lot of small studies with a small sample size, by collating the results of so many studies together, you end up having a larger sample size, and it is easier to identify the statistical significance. So any study metric data can be meta-analyzed, including continuous variables like the mean difference and the percentage, or proportions like the odds ratio, the relative risk, and the hazard ratio. Meta-analysis is not feasible. The study measures are completely with different outcome. Like for instance, if one trial is assessing a pain score, they're addressing the same disease, but the assessment is different. So pain score and the functional ability, it's not possible. And meta-regression and network meta-analysis are now getting done, and these are enhancement to the traditional meta-analysis. So coming to the forest plot, it is a graphical display of findings from the meta-analysis, and it provides essential information for interpretation of the results in a graphical format. Typically, it contains 6 columns, though there could be additional columns to provide a more clear information. And the 6 are basically included studies, intervention group, control, weight of a study, outcome effect measure, and the graphical format of the same. So we are going to focus on this in the next few slides. So let's see how to read a forest plot. So you have the column 1 here. This is the identification of the studies, the study IDs. And these are represented by the name of the first author and the year of publication. And these could be arranged either in the alphabetical order, or these could be in the chronological order, or this could be as per the weight of the study. Generally, it is either in the alphabetical order or in the chronological order. Then this is the column, the two columns, the intervention group and the control group. The small n here is the number of patients having the outcome of interest. And the capital N is the total number of patients in that group. For example, if you were to take the first study, 1 out of 131 participants in the intervention group had the event of interest, compared to 2 out of 133 in the control group. So coming to the fourth column, this is the graphical display. It shows the calculation that has been used is the relative risk with fixed in the bracket with 95% confidence interval. So the box here is the point estimate of the intervention effect. Whatever intervention has been undertaken, the average of that, it basically indicates the area of the block indicates the weight that has been assigned to the study. And when I say the weight, it means how much the study has contributed to the overall statistical significance of the final take-home point, that is a diamond of this systematic review. The horizontal lines indicate the confidence interval. The entire range of confidence interval, the 95%, is indicated by the whiskers of this plot, and the longer lines indicate a wider confidence interval. So the smaller lines, the smaller range means smaller confidence interval, meaning a larger sample size. N is much more, as you can see from here. So the weight in the square, the size of the square is much bigger. So if you were to do a sensitivity analysis, as was spoken in the last lecture, and we wish to, now here incidentally there are only 3 studies. Say if we had 100 studies and we wish to know which is that study which really brings weight to the calculation, so we can remove. If I remove this, would the diamond continue to be here or would it shift? That is what is sensitivity analysis, to basically see the impact of the study in the overall calculation of the effect size. The diamond is the pooled result. The width of the diamond serves the same purpose as that of the confidence interval. In case this is the line, the vertical line is the line of no effect, and this corresponds to one when you have binary outcomes. Which what are the binary and continuous outcomes? I'm just going to be also speaking about those in the next few slides. What I just wish to draw your attention to is the diamond here, which is sticking into one end to the other side of the graph. It is crossing the line of null effect, meaning that the study here is not significant. And how do we know that? We see the p-value here. The value here is 0.7, generally 0.05. Anything less than that is considered significant. So you derive the final effect of your statistical significance from the p-value here. So this is one example of the role of corticosteroids, the use for the neonatal, in the preterm babies, neonatal morbidity and mortality. And the use of corticosteroids, as you see here, they are all favoring steroids compared to the controls. And the entire line. Now, it is important when you derive the conclusion out of forest plot to see which side is what, which favors experiment or intervention and what favors the control. So all of it is to the left, and obviously there was benefit out of the the intervention, and that was the steroid cover. Now, what are the types of outcomes? I had spoken about the binary and the continuous outcomes. What are the binary outcomes? These are anything with yes or no answer. If there is disease or no disease, alive or dead. And the continuous are usually the quantitative ones, the height, weight, blood pressure, serum cholesterol, the walking speed, and so on and so forth. The outcome effect measure here is usually the ratios. the relative risk or the risk ratio or the odds ratio. And here it is the weighted mean difference. And the line of no effect here is 1. Since it is a ratio, it can't be 0, it is 1. When both of them are equal. And if in continuous, it is taken as 0. Generally, when the outcome is adverse, when you want to see the outcome effect and the treatment scale, how to, like I was telling you even in the earlier slide, you look at the side onto which the experiment and the controls are placed. Generally, it is accepted to have the adverse or the decreasing outcomes to be placed on the left side of the graph. But it is always a good idea to pay attention to which is on which side. This could be changed. Then we come to the weight. The weight. Weight indicates the influence an individual study has had on the pooled results. The pooled results, that is the diamond. The bigger sample size and the narrower confidence interval mean higher percentage weight, larger box, and higher influence of the study on the pooled result. And then the column 6 is a relative risk. Everything that has been displayed here. So why do we want to have the graph? Because it has got a good visual effect. Just by looking at this graph, you can see which study is good, which has got a good sample, large sample size, which has got a better weightage. And how are we so confident of doing that? Because we know that these studies have been critically appraised and these are good quality studies. And if you don't have the good quality studies, then you generally need to justify and be able to, also conduct, probably develop a forest plot, but then there are so many riders to the explanation and the discussion that you're going to place at the end of your study. So that is the advantage of having the forest plot here, and the same details are duplicated in the last column. So it is a numerical format of the graph displayed on the column 4, and this can be either the 95% confidence interval of odds ratio, the relative risk, as well as the weighted mean difference, that is the WMD. The average value, WMD is the average value after pooling results of individual studies. So when the 95% confidence does not include 0 or 1, the result is statistically significant. So when the diamond is on one side of this, the vertical line of null effect, it is statistically significant. However, we have not yet spoken of about the details which are mentioned here. So I told you about the p-value, the statistical significance of the result, final result. You look at the p-value here. If it is less than 0.05, then the results are significant. And the next is the I-square statistics. It is extremely important to know about the heterogeneity. So what is heterogeneity? When several primary studies are brought together to provide an estimate, the variability among them is inevitable. So that is what happens, when you write it, when you write your protocol in the paper on your the initial working, and when you really go out, into the field and start working out there in the actual clinical situation, there is always some difference. And because of that, there is expected to be a lot of variations, and these do happen especially when you pool so many studies together. However, it is not a good thing to have a large variability between the studies, because then calculations get affected. So what are the various types of heterogeneity? There could be clinical heterogeneity, there could be variability in participants, treatments, as well as the outcomes. There could be methodological heterogeneity, variability in the study design, risk of bias. So some people could be giving various doses of drugs, various formulations of drugs. For instance, we had done the systematic review on the management of iron deficiency anemia. So when we pooled all those results, we found authors used various kinds of iron formulations. So whether they are really, how to actually get them all together under one umbrella, that becomes a huge challenge. Then there could also be statistical heterogeneity, where variability in the treatment effects are being evaluated. So how does one estimate the heterogeneity? Overlap of the included studies estimates in the confidence. So just let me explain it here in the diagram. So when you see the graphs, where now these, if you were to draw a line here, generally most of these the effect size plots are on the same side of the graph. Whereas if I draw a line here vertically, they are scattered all around it. So here the heterogeneity is less, here the heterogeneity is more. Now, how do I confirm the visual effect? I look at the I-square here. Here it is 38% and here it is 87%. So the heterogeneity is also classified into various the categories. So you look at the 95% confidence interval, the overlap of the maps, the p-value of the chi, and also the I-square gives the magnitude of the heterogeneity. 0 to 40% may not be very important. 30 to 60% may indicate. So there is an overlap here. This is one way of doing it. Generally, it is considered anything less than 25% to be very good. Anything more than 75% is generally not accepted. And this is important to know because the final calculation, the statistical model for calculating the final effect size, the final result is greatly affected by the heterogeneity of the studies that have been included. So choosing the right model for analysis is particularly important. If binary outcome variables are used, and then you come to the fixed and the random effects model, and these are the ones which are used. These are the statistical model to calculate the final effect size of the systematic review. So what are the fixed and random effect size? I'm sorry, I'm having to rush through all this. The forest plot deserves at least 2 days of hands-on workshop. So I would say this is at best just a taster, an overview of what can be done. So I hope there is some clarity in this. So what are the fixed and random effect model? So here are so many studies which have been grouped together on both the sides. The fixed effect model believes that there is only one true effect. You combine 10 studies and you think that they are all going to have the same effect. So all the results will fall, they would be somewhere close to the central line. However, the random effect model, it believes that the distribution of effects is very varied. Now, if you look at this plot, this is the true effect as per the fixed effect model. The random effect believes that it could be on either side. There is a distribution of effects on both the sides. And the summary of the effect is a mean of so many distributions around the null effect line. So the weightage of the studies in the fixed effect model is given by averaging all the studies together, whereas the random effect model takes an average of all these studies when they are pooled together. So the kind of statistical model that you use also brings about a great difference, change in the outcome of your study. So what I said was choosing the right model for analysis is especially important if binary outcome variables are used, as fixed and random effects models give different results. So this is what I meant. So one has to be especially careful when you're using a binary model. So when you're using a fixed model and you have odds ratio, risk ratio, and the risk difference. So these are the various kinds of statistical methods that can be used. Why is it important to know this? It is important to know because when you're constructing your forest plot in the RevMan, then you have a choice to fill in what kind of statistical calculation that you wish to use in your forest plot. So there has to be some idea as to what you wish to use. So what are the pros and cons of a forest plot? It is very good. It shows you the heterogeneity. The pooled result is also demonstrated well. However, the problem is in the direction of publication bias. So time and again, since afternoon, right from the first discussion, I think a lot has been already spoken about the publication bias. The majority of the good studies, positive studies get published. Negative studies may not find a good place to have their publications to be presented to. So although the intent of a meta-analysis to find and assess all the relevant studies, it may not always be possible to find these studies. And there could be also the language restrictions. Because if I restrict my search only to English language, I don't have a translator in my team, that could also be a big problem. So while it illustrates heterogeneity and the pool result well, it doesn't display the publication bias. So for this, we need either a funnel plot or there could be something called an Eggers analysis to identify if there is a publication bias. So I come to the last part of my talk, how to draw a forest plot. And here we can use a statistical software which is available from Cochrane. It is free. And we have the Revman on web, or you could download it. Now they encourage Revman on web as the most preferred one. And in case you're doing a non-Cochrane analysis, the choice is also available. You can choose the non-Cochrane as the choice. I don't think I would be talking about the Excel sheet because it is a little complicated. So what I have done is I've developed a small video on this so that we are able to, understand this easily. So this is the Revman, and I have already, I was working on this acupuncture for treatment of insufficient lactation for in the postpartum period. So I have already included the studies. How we are going to do that, I think that most of us would have to learn that. But today I'm just going to show how to develop a forest plot out of this. So after having included the studies, so what I do is I go into data and analysis, and then name a new comparison. So here I wish to add improvement in lactation, and then add an outcome under the new comparison. So it is dichotomous. The name of the comparison would be weight gain amongst the improvement in the weight in the neonates. Right. So this was what I was talking about. So you could be asked about the statistical method that you wish to choose. And then we want 95% confidence interval. So I want the experimental and the control to be shown. Nothing after that. So go back to the data and analysis. Go to the key. Choose the comparison. And now you need to add the study data. So these are the studies which are included in this. So here you need to manually enter the study data. So this is the data that I'm entering now is only hypothetical. So we have the experimental and the control columns here. You need to enter, go through the study and enter the data. Right? So you do that for all the three. So as you can see here, the forest plot is developing here. So then you finally go to the forest plot display there. And then if you wish to add this as a figure to your systematic review, then this would be the way it will look. So that's it from my side. No, I think I have more slides, sorry. So in a nutshell, this is basically the outcome of the final, the conclusion of the talk. So the meta-analysis, the forest plot basically shows the review title here, the included studies, the intervention and the control groups, the graphical display, the kind of statistical method and the fixed or the random effect model that has been used, and then you have the study weights, the confidence interval, and finally the final result, that is a diamond that is there. And then you need to also know the line of no effect. Now this is for a binary outcome, and here you have the continuous outcome. The line of null effect is at 0 here. This is at 1 here, and it is generally it is important to see that the continuous data could have figures in negative values, whereas the ones which are the binary outcome generally actually doesn't ever have the negative values here. So here the numerical that is expressed is for the WMD, and here you have the relative risk. Then you have the heterogeneity, the I-square statistics which are expressed here, and the p-value to show the statistical significance of the finding, the final takeaway. So having read all this, how do we translate this to practice? It is important to know that clinical decisions in medicine should be based on guidance from a comprehensive assessment of the body of available knowledge. And that is why we wish to undertake systematic review, which occupies almost the pinnacle of the pyramid of evidence. And anything beyond the systematic reviews are the guidelines, which are based on well-conducted systematic review. So if you have good guidelines, it is a very good idea to take those to help you to take a decision. But otherwise, then you go through the systematic review, and the meta-analysis in the systematic review present data from multiple individual studies, and these could be either randomized trials or observational studies too. So meta-analysis is also possible for observational studies where randomized control trials are not available, and those meta-analysis of the studies which address the same question. So the forest plot summarizes and displays the results. It also allows the readers to estimate and to know the final result, and also the precision of the individual studies. So precision meaning what? It was again the weight of the study. So if it is a smaller confidence interval, a larger area of the square, it is a surrogate marker of a good precise precision of the results of that study. It is also important to appreciate the heterogeneity of the results and compare the estimates of the individual studies for the overall summary estimate. So since meta-analysis involves multiple studies, and there are which are individual and distinct in their own cells, it is important to bear in mind that the overall results may not be directly interpretable to a single patient who is sitting across table. And so though it does provide an overview, you still need to use your experience to translate that into practice and to apply it to the patient. So things change with time. So what was good yesterday might not be so good tomorrow. So we need to keep our ears and eyes open and be updated with the latest trends and also the meta-analysis. Thank you so much for a patient hearing.
Shikha, you're muted. Shikha, you're muted.
It was a very nice talk, and I think I have cleared some of my doubts regarding interpreting the forest plots, and I'm sure it is very helpful for all the students. Thank you.
Thank you.
Radhika, I just had one question.
Yeah, sure.
That you spoke about forest plots. So supposing a forest plot is made by not the excellent studies, and there are studies with bias in them, are they put there? Is the bias put there? How do you do it? Or forest plots are only put where studies have very little bias?
See, our choice is to have the best possible. So that is why one would have already done a critical appraisal, which is the step 2 or 3 of systematic review. So the thing is, it has got it is got an inbuilt thing of showing up, because the size of the confidence interval, the size of the weight, everything shows. So if there has been heterogeneity and if there is a improperly conducted study, inclusion of that in your systematic review is not a good idea, number one. However, if you have, because if you don't have good quality studies and you end up doing, you just want to finish off with that systematic review because you want to develop some kind of evidence, then you would be putting that in your discussion, and it will also show up in the forest plot to some extent by, it would be variously placed on both sides of the graph, of both sides of the null line, and also the size of the sample as well as the weight of the squares will show up in the graphical display. Okay. And then you have the risk of bias. See, the systematic review completes with not one aspect only. Yeah. When you see the full text of a systematic review, all of it is included there. So you need to refer to the results section. You need to see the forest plot. You need to see the risk of bias table. And then finally, the discussion by the authors, and also the limitations and strength of the study. So from there,
just the forest plot will not tell you the bias. You have to go into the text to get the bias, right?
Or you also see the risk of bias table.
Yeah.
It takes time. It takes time to finally analyze a systematic review in complete completely.
Yeah, thank you.
You're welcome.
I think over to the last talk of this interesting session. Dr. Mohan Kamath has already been introduced.
Yeah, we'll just go ahead, ma'am. Yeah. Just a couple of comments. As Madam was saying, the risk of bias, those circles will appear on the forest plot. So we can actually make out if it appears on the forest plot. I think one of the slides I did show.
That is what I wanted to know.
Those circles will be there, ma'am. It's like green, all that I call, along with the study trial. So that's something. The other message is like forest plot and all that. We don't, as clinicians and end users, don't have to understand all the complex things, statistics and all. It is a lot is done by the software, as Madam so beautifully showed in that video. It's just that we feed the data that Raju has told. We are just filling in those boxes and the forest plot is generated. So we are not actually sitting and doing all that. So we don't have to get too anxious and worried about those.
Overwhelmed with all those.
Yeah,
yeah. So, that's why I don't want to focus on that too much.
Yeah. So just the broad concept has to be cleared, and so that we understand where it is coming from. But the nitty-gritties and all, we can leave it to the methodologist and the reviewers to do it. But as an end user also, we should be knowing how to interpret broadly. That's all I would say at this point. And yes, so this is the last talk, and this is not much or heavy on statistics. It's a very new way of evidence synthesis. So I thought it is relevant that we know this now. There are a couple of reasons why. One is that it's a new method of evidence synthesis, and which is considered superior to systematic reviews. So that's one thing. But second thing is, it is also important that all of us who are doing randomized trial know about this, because there are some implications that I will touch upon during this talk. So we are talking about individualized participant data meta reviews, which is in short called IPD reviews. And just next 20 minutes, I'll probably rush through and go through what it is and what are the advantages, briefly on processes and benefits. I happen to be on one of the IPD reviews, and it's a learning lesson for me also. The stats part is a little more complicated than the systematic reviews. So I won't touch upon that as of now. So we are all looking at evidence, and most of the times I find people quoting the evidence as evidence-based medicine, but remember that we have the judgment and the patient value. But the problem here always and will be is how to critique the evidence. So this all exercise is trying to figure out how to find the best possible evidence. So we were at this pyramid. I think this is shown by Dr. Ruma already, but now world is slowly moving on and added one more layer to this, which is, I think IPD reviews will go one step beyond systematic reviews. So all of us need to be now aware of this particular entity. So we are doing primary research, RCT, we have dwelled upon it. That was the first session. As I said, it's easier to understand, difficult to implement and finish. So we have bureaucratic issues. You have to go through the ethics and trials registry, and finally you get your RCTs done. Systematic reviews also are good. It's a ready reckoner, but then remember that sometimes we will never be able to complete a systematic review with the meta-analysis in it. That is, we will not find similar trials for pooling them in. So that brings to the point, if you're looking at these are the steps and you're looking at data analysis, that is pooling the results. That's what Dr. Radhika ma'am covered, meta-analysis. Okay, so this is what we were shown, and we were using I'm just showing this forest plot and just showing you these are the pooled results from the ovulation trigger Cochrane review, and you can see that one study is 76% weightage and other one is 23%, and we got our final results. The assumption being made here is that the trials are fairly similar with very less difference, and we kind of go ahead and combine them. The problem with meta-analysis is that many of people believe that you are actually putting in apple and oranges together. That is, let's say if I do a trial here in CMC and somebody does in Delhi and somebody does in UK, and with the same PICO statement, we are assuming that they are quite similar in comparison. But even if they share the same PICO statement, there can be huge differences on ground. And this is something that you and me will realize, that the patients that come to my department or my unit here might not be the same as what is coming at Delhi or any other country, if you that other continent as well. So that's the problem. Trying to pull in results from very different studies, which on surface look similar, can lead to very imprecise results. And imprecise essentially meaning that the results are all over, you know, it is some of them are showing benefit, some of them the pool results are, there's a very wide confidence interval, and ultimately we end up saying the evidence is insufficient. And that's what the conclusions of most of the reviews end up with. As we said, that meta-analysis is not about just giving averages. It actually gives some weightage, more weightage for larger trials. And remember that some studies are obviously having more weightage because they have larger sample size and more number of events. Essentially, it makes the results more precise. I'm just trying to. Okay, yeah, I'm just seeing as the same presentation. Okay, okay. So I'm just showing you what meta-analysis is doing. If you actually just look at these two, this is nursing intervention for smoking cessation, and you just combine the experimental and control, you see 15% of them are quitting. Okay, this is the normal averaging. But when you do meta-analysis, it actually gives more weightage to one of the studies. You can see here clearly 46% weightage, and it kind of contributes a larger, it contributes more. And that's what Dr. Radhika was trying to say. So essentially, I'm just trying to show that each of these studies are different, even though they have the same PICO statement. But this is how meta-analysis is being done. So 1.26 means that essentially 26% extra people have quit because of the nursing intervention. Whereas if you are just looked at the average, you are not done a meta-analysis, you just put them together, there was not much difference between the two arms. So that's why you can make out that some studies which were better, larger, were given more weightage. More larger studies got more weightage. Now, if you have to ask now, after all this, how similar are the studies, even if they have the same PICO statement and full eligibility criteria are all matching? So the same point explained, there will be subtle differences in inclusion and exclusion. What you decide in your unit might be slightly different from mine. There is also an issue about outcomes. So your definition of clinical pregnancy might vary from my definition of clinical pregnancy. I might put it as ultrasound detected gestational sac as a clinical pregnancy, whereas you might put it as positive pregnancy as well, or patients with certain other beta HCG values as a clinical pregnancy. So all those things will start bringing in clinical heterogeneity. That's what Dr. Radhika ma'am was trying to say, that there will be some heterogeneity which is clinical. Okay, and there can be statistical analysis issues. We also don't have data on subgroup. That means which set of patients are actually benefiting. There might be some patients, let's say the COVID vaccine, there might be a group of individuals which might be getting more benefit. But when you have a trial which is putting all the patients, let's say elderly, pregnant women, young people, everybody together, and you present that data, it will be very difficult. We will just know it is benefiting a bit, but there is definitely a subset of patients who might be benefiting more, and that the systematic review is not going to be able to answer. Okay, because the randomized trials will pull in all this. We call it unselected data. Like if you take an example of IVF, you might pull in patients going, women undergoing IVF. You might have some of them who are undergoing the first IVF, some of them 2 IVF, some of them 3rd IVF failure, and so on. and pooling them together brings in the clinical heterogeneity. It also means that we can't inform the end user, that is you and me, whether this intervention, let's say screening hysteroscopy, is working in 2 or more failures, or is it working in the first IVF group or not. So that is something that the systematic review will not give you an answer. And this is all fueling in heterogeneity, basically, essentially meaning that they are having subtle differences, which is going to create problem in drawing up the conclusions. Just to inform the audience here that because of these problems, now there is a group of people across the world. It is called the COMMIT, COMMIT initiative, which is trying to standardize the definitions across the infertility landscape. So how are you going to define live birth, clinical pregnancy, or ectopic pregnancy, and so on? It is advised that future trials use this particular COMMIT initiative definitions so that it can be standardized and used for systematic reviews. Because so much has been learned while doing these systematic reviews. That's why I'm just sharing how it is leading to other initiatives. So essentially in an IPD review, you will have the same steps until you come down to collecting the data. And this is where we will start going different. Until you have identified your number of studies, let's say you've got 10 trials, that's where the systematic reviews starts differing from IPD review. Now, what are we going to do? So we have said this, we got the same number of steps still here. And from now on, I'm going to contact individual authors and ask them for the data. That is, the people who have published their trial, we will ask them and request them if they can share an anonymized data set. And if you say yes, then obviously things will move forward. So there is something called data cleaning. So we will ask for only certain variables. We are not going to ask the whole data set, but we will not ask for patient identification as well. But there is a need to share the data. If let's say I agree with a particular group, then we had to have something called data sharing agreement. And this is something signed between two institutions. So like we have shared, we have done a data sharing agreement with one of the groups in Europe, and we are sharing our data on one of the trials. So now, if you are planning to do a randomized trial in our country, you should be willing to, there is a column in the registration form which states that you have to commit whether you will be sharing your data or not. So you can see that there has been an evolution of methodology. Things are becoming more stringent, more strict. So you are supposed to be committing. That is, that when I submit an article or manuscript for publication, I'm supposed to agree to sharing my data. Now there are 4 levels, level 1, 2, 3, 4 for a journal. So if you are planning to submit an article to, let's say, human reproduction, you are supposed, which is, I believe, level 2, means that you should be able to share your data if asked under certain circumstances. But there are some journals like probably Lancet and NEJM where they will ask you the whole raw data. Okay, so be very prepared about this. That means that your data has to be absolutely valid and transparent. This is all the responsibility of the principal investigator. Now, when the central team approaches the trial authors, we sign up a data sharing agreement. So what we did was we went through our ethics board. We didn't want to take a decision in our department alone. We felt it's best that involve the institution. You go through the institution and ask for a approval from the institution because it's the data from the institution. And then there are other issues. So let's say I'm sitting here and I'm trying to do a IPD meta-analysis, and I ask my European colleagues to share their data. They might come up with this, that their country does not allow personal data or the patient data to be sent outside their country. So there can be country specific embargoes. So one of the ways is, if the principal team member is from other country, a European country, they might find it easier to push through, but we might find it difficult. So now the interesting part comes. So once you start approaching, let's say you start approaching 10 authors of that, 10 trial authors who have published their RCTs in a manuscript. Now, out of those 10, there will be many who will not be ready to share the data. Why? Do not have the data because it was done when I was a PG and it's got lost. Those were the days when we used to just do everything in a physical format. Second is I might have my doubts about the validity of the data. Third is there can be legal issues. Fourth is there is a problem of fraudulent trials which are coming up, and this is creating a lot of problems. I will touch upon this again. So ultimately the problem is, while the systematic review would have picked up 10 manuscripts and 10 trials and pulled in the results, IPD meta-analysis might not get the data from those 10 authors. They might get it from 4, 5, 6, if you're lucky 7, 8, but not all. However, if you have agreed and you are able to do, then it is an anonymized data transfer. We don't put the patient number, we kind of create a new code. So like we have created new codes for that, and which we link it with our data set, and we do it, and we only give this to only certain variables are given. So let's say if they ask only patient age, BMI, and infertility, primary infertility, secondary, and so on, we don't have to give the whole variables. Whatever they have asked, we will give. Now, funny part was like when we shared, they wanted to know the smoking history, but we didn't capture that. Okay, so it's kind of cultural thing. Like it didn't occur to us that we should capture this data, but because we get patients from a very different landscape. But then this is something of a norm in the European studies, and we didn't share this particular variable for that particular project. Now it gets more interesting. So what happens is once they have got your data, they are likely to rerun the analysis and see if the baseline and outcome tables are replicated from what has been published. And this can lead to problems. So if we have not really done our job well, and you have published something and then they figure out that the results are quite different, then it is a potential problem. Now, I am privy to this, that this happens, and see, minor discrepancies can be ignored, like 0.1 ki jagah you have put 0.3 and all that, it's okay. But there can be times when the results were actually opposite and what was published was different. So, and it can be out of ignorance. So that's the problem, and it can uncover all this. There can also be data integrity issues. As I said, we have become good detectives now. So the baseline variable tables can be quite informative if you really, plunge into them and try to dig around a bit. So this can lead to some trials coming under suspect category, and then many times the projects will have an ethical committee, or ad hoc basis they will create a committee which will look into these, give the authors a chance to rebut. So authors will be asked for clarification, and sometimes we might have to approach the university. Authors will give a response and we'll have to take it. So sometimes they say that we don't have the data, and we kind of take it and we kind of mention it, and it is excluded from the review. Now, that's where I was talking about getting data. Now, once you've got your data, things get a little more smoother here. You just run through your analysis, pool them together, and you'll get your results. However, the main advantage, as I said, is that you will get much more answers about your subgroups, which is not the case with main systematic reviews. That is, if I want to know if the intervention is working in 2 or more failures or first failure, I will get more data on that, because you will be having a master data sheet of all the trials. So you can really look into it and see whether we do it something called interaction analysis to see whether the intervention is working better in a subset of patients. And this is the main advantage of a IPD review. it is also called precision medicine. It is helping us individualize better, which is not the case with systematic review. Systematic review, as Dr. Radhika said, it is an overview. It will just tell probably this is working or it's not. It is not telling us where it is working better. And the results, as opposed to what is presented in systematic review, which is just a crude ratio, here you can adjust for prognostic variables. That means you will balance some of the prognostic variables like BMI, age and all, and you will have to present the adjusted results. This is a little complicated to put through, but what I essentially I'm trying to say is like it's a big, large randomized trial. All 10 have joined together with their data and converted into one large trial. That's what it is. Problem will come when you have something called missing variables. That is, certain variables are not there, and there is something, a statistical exercise done called imputing, which will kind of fill in. So don't worry about it. It's just that remember that if you have a lot of missing variables in this data sheet, it can create problems, and there are statistical methods to figure that out. That means, let's say if my trial did not capture live birth rate, whereas the remaining 9 trials did that, then there is a sophistical statistical software to address this issue. So those are issues when you are actually going on. Like I have mentioned here, RStudio software and so on. I am not expert on all these things, but I know that these problems do come when you are doing an IPD review. Finally, when we present the data, we want to see what are the results when you have done a systematic review the way we have mentioned it, and what were the results when you're doing an IPD meta-analysis. So systematic review might have pulled in 10 trials, whereas our IPD would have done 8 trials. What are the results? And also within the IPD meta-analysis, there were, let's say, only 6 people who collaborated and 4 refused to collaborate. If we combine these 4, like the results from collaborators and non-collaborators, is the result very different? Suppose the results are fairly similar, then your results are more robust. But if you find that the collaborators, when we pull the results from them, the results are different, and those who refuse to give the data, the results are different, then we have a problem. Okay, so all this is being still, it's an evolving technology, evidence method, but just be private. The best part is the carrot here. Each of the unit gets an authorship on it. Okay. So if you are a large trial person, you will have a couple of authorships. The core team will be there, and each of those trial people will get authorship. So essentially from the same trial, you'll get 2 papers. So that's the carrot here. The stick I have already mentioned. Now, how many people can get in? So now the problem is the whole unit wants to be the author. That's not going to go. You will have only 1 or 2. So like, for the IPD review that we were there, we decided if a trial had 200 participants, you'll have 1 author. If you had 400, more than 200, we'll give 2 authorships and so on. So there is a trade-off there, but everybody will not be on board. Otherwise, it's going to become like 100, 200 authors and all. That's not done. So essentially, that's where the carrot comes. And then we have the review done. So just to give you an idea of the scale, in 2018, there were 14,000 systematic reviews as opposed to 140 IPD meta-analysis in the medical science. So this is gaining ground. So typically after the systematic review, many of the IPD project people will contact the systematic review authors for help in moving on with IPD reviews, because they can use the same screening strategy and contact the authors from this particular group. So it kind of is collaborative. Advantage, as I said, IPD review will give you more idea about the subgroups. It has more uniform eligibility, so you have a more homogeneous data and less heterogeneity. Results definitely are more valid if you ask me. So if you have an IPD meta-analysis coming out for a topic, I will go for that rather than a systematic review. Implication for practice, obviously the clinicians will be benefited with more robust and valid results to guide clinical decisions. Just to give you an idea, this is one of, I'm not there in this, but I know many of them. Rui Wang is one of my friends who is doing a lot of IPD meta-analysis, but just see the number of authors. Many of them have trials on this topic, and that's why they are there. And this is the main core team here, which has done the review. If you want to know more about IPD meta-analysis, this is open access. That means this particular systematic IPD review is accessible to all. It's in Human Reproduction Update, which is the highest impact factor journal in our specialty. Anybody can access this and they'll learn a lot about IPD meta-analysis. That's about it. I think if I just capture this particular manuscript, what it did was it gave us much more robust results about letrozole and ovulation induction drug, but it also gave us a very important outcome, that is time to pregnancy, which was not there in the systematic review. So not only it told us that letrozole is doing better than CC, it also gave us a very important outcome, that is time to pregnancy, which is now becoming very important. It is a very important outcome in cancer trials where time to survival analysis is done. But in our specialty, time to pregnancy is equally important. And it kind of gave us this data. So it's a very interesting article, which I urge everybody to go through for getting an understanding. Take home point, what I want to caution here is the trial team now has an additional responsibility. If you are a primary author for a trial, you will be approached by people for data. It's a good thing for the larger scientific community. So we have to ensure that our data is valid and it is available for sharing, but which is a requirement now even at trial registry stage and at a manuscript submission stage. There is a movement going on. I already mentioned COMET movement, which is essentially trying to standardize all the outcomes. So the future studies will have to have these outcomes to go by. IPD meta-analysis is the way forward. And I think both the primary and secondary researchers benefit, and it helps in getting more robust results. I stop there. Thank you. Okay.
Dr. Surveen, you're not audible.
Thanks, Mohit. That was very, very enlightening. From what I can see is that this is like a multi-centric retrospective trial. Am I right?
Yeah, it is basically trying to get data from all the trial people, but the trials are already published.
Done. So I just had one or two questions. I want to know that, what is the issue with the journal if supposing your data is not okay and it is declared not okay? So what does the journal do? Because the article has been published. Is there some guideline on that? That what would the journal withdraw the article? Would it publish?
So actually what happens is if there are people who might just then approach the editors, if they have concerns with a particular trial and write to the editors, first they will write to the authors and then pull in the editors, and editors are supposed to take a call on retraction. Now, what I understand is the retraction rate is very low. It's around 2 to 5%. I know certain people who are doing a lot of work on this, but retraction overall is very low because nobody wants to take up that hard step, and that creates problem. And yes, so the editors are supposed to take cognizance of this and probably give a fair chance to the author team as well. And but the overall thing is that we have to be responsible in our conduct of studies. And the amount of responsibility, as I see it, is increasing day by day. It is no longer just saying, I will do a trial and then you don't have the data to share. That is now frowned upon. The whole idea is to minimize the research wastage, have your data and help everybody collaborate. That's the whole idea.
I also wanted to know that, if the non-collaborative data and the collaborative data is not matching, then what do we do? Like if it's totally different, then is there a statement to be passed?
No, this basically the review people will be very transparent in the way they present it, and we will leave it to the wisdom of the people who are reading it, how they want to interpret it. But obviously, if you ask me, the people who are collaborating, that data will be carrying more weightage than the people who have not shared their data. So and that's what
this will evolve as the data probably to refer to.
Yeah.
One more question I had was the COMET which you mentioned. Have they done it, or if they're in the process, can we access it?
Yeah, so I'm part of this team, which is already like 2-3 articles are published now on infertility, and also I'm on the male infertility ones where they are doing a Delphi's consensus across the world, across all the continents, and saying what is the agreed definition on this. So I think if you just type Google and see COMET, you will get 2-3 articles in human reproduction, where there is a big collaboration going on to standardize the outcomes, and all of us should probably move towards using these outcomes.
So COMET is COMMIT?
Yeah.
Okay. Thank you. That was very good. I think all 3 lectures were wonderful.
Thank you, ma'am.
Thank you so much.
Dr. Shikha, would you have any more questions?
I just wanted to read your question. Why to have COMET when we have ICMAT? I think.
Yeah, because there are a lot of jobless people like us. No,
why consider?
No, I get that. It's just that they felt that it needs to be refined further. And what I understand is it's going to go much more in depth in terms of areas. So male infertility one, then IVF things, and then infertility at female and male, like that. So it's a lot of work being done by certain groups. I've just happened to be on one of them, and mainly they are trying to, this is Delphi consensus is the method. And what I understand is now even in Cochrane, we are supposed to use these outcomes for framing the systematic reviews. So they are not, ICMAT is being done till now, but they want us to start quoting COMET initiative. It is called the COMET initiative.
So I think the last talk was absolutely enlightening, as Surveen said. That was very interesting.
Well, so was yours. For us, yours was also very nice.
Oh, thank you.
It's just that we were a part of it, and it is just that it is just about pooling all our resources so that our trial, even if it's published, can be useful, provided we share the data, because then you can put all this, as Madam said, it's like a retrospective multicentric trial, but all of us should be on the same page in terms of what we've done.
No, I think that it's a very good initiative.
Yeah.
Okay. So I'll take it on from here.
Thank you.
At the end of this enlightening session from our 2 stellar speakers, I'd like to thank our chairpersons, Dr. Surveen and Dr. Shikha, for being there. Our experts, Dr. Siddharth and Dr. Anupama, along with Dr. Mohan, who chaired the first session, and the chairpersons, Dr. Sangeeta, Dr. Harpreet, and Dr. Arvind, who's not with us. But yeah, thank you for being there. Hopefully the delegates have managed to, this workshop has managed to incite some curiosity, even if there was none, about systematic reviews. And in those who already had that curiosity, it has managed to kind of ignite that little spark in pursuing systematic reviews further. Thank you all for being here. I'd also like to thank the Conference International team for doing this remarkable job of coordinating the workshop. And of course, Dr. Sudha Prasad and Dr. Neena Malhotra for giving us this opportunity. Finally, I think that should be all. I don't know if this is our last workshop, but Dr. Mohan would be able to tell us if he would be conducting.
Yeah, I think thanks, Dr. Ruma. I think we both have, probably this might be, we are finishing our tenure, so we thought we will stop with systematic review. And I thank Dr. Ruma because she's done quite a bit of coordination. I was mostly just there. And we hope that we kind of have tried our best to, because the COVID did have certain limitations. We could not do anything physical conference and so on. I think the research methodology is a very heavy topics, and physical conference would connect better. But we could try whatever through virtual, which in a way has its advantages that people could access without traveling. So we hope to continue supporting IFS and all the researchers across the country in whichever way we can. And happy to, we are there to probably respond to any queries and guidance that we can do possibly. Thank you all.
IFS is not letting you go, Mohan. Okay, you're going nowhere.
Let's see, ma'am. Okay, thank you very much.
Radhika, thank you so much.
Yes.
You
Thank
have
you.
really cleared many issues for us. Thank you so much.
Thank you.
Thank you,
I
ma'am.
enjoyed being here. Thank you. Thank you so much.
Thank you. Thank you all. Bye.